that is State Health Center, Pune, which is the wing of the NHM, Government of Maharashtra Health Department, Public Health Department. We regularly conducting the administrative webinars and clinical webinars every month to have the updates on the knowledge of the medical officer across the Maharashtra. We have started this activity from the September 2022. Nearly 14 months or 15 months we are doing this activity relentlessly for our medical officer who are situated far away in the Maharashtra, in the rural region, urban region, tribal region. From last 14-15 months, we have conducted the different topics webinar. We have called the eminent person from the AIMS, Nagpur, AIMS, Delhi, Raipur, various medical colleges, various renowned hospital consultants to have a talk with our medical officer to answer their queries, to update their knowledge. Till now, we are mostly focusing on the communicable diseases which is the prime motto of the public health department. But now we are shifting our focus a little bit with the non-communicable diseases. As you know, the 63% of the all deaths are due to the non-communicable disease nowadays. Previously, we are focusing on the communicable diseases because we are having the epidemics and mostly the communicable disease death. But now the focus has been shifted to the non-communicable death. And of these all non-communicable deaths, nearly 27% of the death are because of cardiovascular elements. In 2003, there are 17% death because of the coronary disease, which has increased to 23% in 2013. In the last span of 10 years, there was shift from 17% to 23% in the coronary disease. Now it has been called as the India is on the brink of the epidemic of the coronary artery disease or coronary artery syndrome. Or we may say that we are already landed into the epidemic. India is also called as the capital of the heart disease because of all these things. And the worst thing is that nearly half of the death because of the coronary artery disease occurs in the age group of the 40 to 60. And all you know that the risk factors, mostly the risk factors are modifiable or the preventable, like the tobacco smoking, high cholesterol, lack of exercises, obesity, stress, leading to hypertension, sedentary lifestyle, unhealthy lifestyle, poor dietary habits. These are all preventable causes of the coronary artery disease. And we are focusing on that. We are getting the acute disease, acute coronary disease and chronic coronary disease. Acute, which is sudden reduced blood flow of the coronary arteries, and chronic, which is the stable ischemic disease. Gradually, the coronary artery gets narrow and narrow because of a number of things, which our eminent speaker will elaborate in deep. From the government of Maharashtra, today our director, Dr. Ambadekar sir, is unable to address our webinar because of some or other reason. As you know, that the assembly session is going on in the Nagpur. But government of Maharashtra is also doing a very good thing. They are having the STEMI project across the Maharashtra in 12 districts. There are 145 health facilities have been selected and they are operational and working as a spoke where the ECG facility is there. And if the ECG is taken with the help of the AI, you get the instant report whether this is ST elevated myocardial infarction or not. And it is linked to the 38 hubs where the diagnostic facility is available, thrombolysis is available, and finally it is connected to the cardiac cath lab. So in this way, this hub and spoke model of the STEMI activity runs in the Maharashtra. We are in a process to attach the remaining 22 districts of the Maharashtra to encompass all the Maharashtra state. The STEMI project not only deals with the ECG and reading of the ECG with the help of AI, but also in the preparation of the protocols for the treatment and management of the coronary artery disease. The immediate treatment and thrombolysis facilities at some of the places like the hub, and then the nearest cath lab if the surgical procedure is required or any other procedure is required more than thrombolysis. Then the ambulance facility which is required for the referral in our golden hour is also included in these STEMI facilities or STEMI projects. In this way, Government of Maharashtra, our NCD cell is doing very much the important activity in the coronary artery and the cardiovascular elements. Today, we are having the good webinar and the eminent speaker with us, updates on the diagnosis and management of the acute and coronary syndrome. Today we are having Dr. Ajit Bhagwat and Dr. Ranjit Palkar deliver a lecture, have an interaction with you and answer your queries regarding the coronary artery disease or coronary artery syndrome. Dr. Ajit Bhagwat, who is the director of the cardiology in Coronary Hospital, Aurangabad, will deliver the lecture on the diagnosis and the management of the acute coronary syndrome. And Dr. Ranjit Palkar, who is also consultant interventional cardiologist at Coronary Hospital, Aurangabad, he will have a talk on the diagnosis and management of the chronic coronary artery disease. We have separated two parts, acute part first and followed by the chronic coronary part syndrome. Dr. Ajit Bhagwat sir is there? Dr. Bhagwat sir?
I'm here. Can you hear me?
Yeah. Just I will introduce Dr. Ajit Bhagwat sir. He is a director of cardiology, Kamalnan Bajaj Hospital, Aurangabad. He himself is having the n number of degrees with him: MD, DM, FACC, FSCI, FESC, FISC, FCSI. It is difficult to read all these degrees. He is a diplomat American Board of Cardiology. He is a diplomat American Board of Internal Medicine, fellow of the American College of Cardiology, European Society of Cardiology, and taught all the university exams, right from the MBBS, gold medal in MD Medicine and DM Cardiology from Mumbai University. He was the president of the Indian Society of Electrocardiology, 1920-21. He got the Best Viewer Award of the Indian Heart Journal in 2015. He has 87 publications in the peer-reviewed journals like the Heart, JACC, and all these under his belt. The chapter as the first author in the Cardiology Clinics of North America, Gerson's Textbook of Nuclear Cardiology and CSI Textbook of Cardiology. He is the principal investigator of Tuxedo 1, Tuxedo 2, Select, Emperor Reduced and Emperor Preserved, and GS trials. I request Dr. Ajit Bhagwat sir to deliver his lecture and answer the queries of our medical officers who are serving across the Maharashtra in urban setup as well as the rural setup on the diagnosis and management of acute coronary syndrome. Dr. Bhagwat sir.
Thank you, Dr. Deshmukh, for your kind introduction. Can you hear me?
Just I will interrupt. Meanwhile, we are putting the pre-test on the chat box. Kindly go through it.
Okay, can you hear me, Dr. Deshmukh?
Yes, sir.
Okay, so thank you very much for your kind introduction. I will be speaking on acute coronary syndrome. I will share my screen now. Okay. Can you see the screen?
Yes, sir.
Okay. So, is this the entire screen? No.
Whether the presentation is visible to you?
Are you able to see my presentation?
Yes, sir. Yes, sir.
Okay. No, actually, this has to go on the whole screen. Just one second.
त्यांना दिसणार नाही समजून. आपण ज्यांना शेअर केलं
हा.
त्यांना हे दिसणार नाही पूर्ण झूम केलं की नेक्स्ट स्लाइड.
That's okay. So I think I'll start the talk. My talk is on pathophysiology, clinical features, and management of acute coronary syndrome. So before I start, I would like to thank Dr. Sanjay Deshmukh and his entire team for inviting me and Dr. Palkar for this symposium. I understand that many doctors, medical officers from health services are going to be participating in the symposium, and I welcome them all for this symposium. All of you must have heard about acute coronary syndrome. This is a very commonly used term. I'm going to keep this very simple, not make it very complicated, because many of you may not be practicing active medicine or cardiology, but at the same time, it is very important to know what these clinical entities are and what is their current management clinical features. When we were studying during our MBBS days, this acute coronary syndrome, this term was not actually in vogue. This came a little later, maybe I would say late 80s or early 90s, when it was recognized that even the coronary arteries have behavior which is similar to acute diseases like, sudden onset of pneumonia or sudden inflammation somewhere in the body. So before that, when we were studying in our college in late 70s, early 80s, what we knew was acute myocardial infarction and angina pectoris. These were the two terms which were used. But now we have an entire spectrum of coronary artery disease which varies from acute coronary syndrome, which has got 2-3 entities under it, and the chronic coronary artery disease about which Dr. Palkar will be speaking about. So what is ACS? It is sudden transient interruption of coronary blood flow related to the atherosclerotic plaque. Now, when this interruption in flow is incomplete, we get non-ST elevation MI or unstable angina. Okay? And when this interruption in flow is complete, we get ST elevation MI. Now, these two are separate entities. They are topics by themselves. So in today's talk, I'm not going to talk about ST elevation MI, but I will be mainly talking about non-ST elevation MI and unstable angina. ST elevation MI, as I said, is a topic by itself. It will take another complete 1 hour to talk about it. Now, this is what atherosclerosis is. If you take a cross-section of an artery, you can see this lipid plaque which is accumulating here, and then there is a cap, and this is the lumen of the artery through which the blood flows. So this is a stable plaque. This yellow material is a fatty material which gets accumulated in the artery. Now this is what happens in acute coronary syndrome. This plaque, yellow plaque which was there now is ruptured. This thin fibrous plaque gets ruptured and you get accumulation of blood clot on top of it. And now you can see that this is a ruptured plaque. Compare it with this. This is a very clean looking plaque. Okay, so this patient doesn't have any acute coronary syndrome. Whereas here, this plaque is ruptured, there is a thrombus here, and when the thrombus goes on increasing, it encroaches on the lumen and the coronary flow decreases. Now this happens suddenly. That's why people with acute coronary syndrome get chest pain of acute onset. Suddenly they wake up from sleep or they're at work and they start getting chest pain all of a sudden. Now this is the angioscopic picture. If you put a camera in the coronary artery, you can see this plaque, you can see this clot here. So this is a similar angioscopic picture. Now, what would you see in a post-mortem specimen? Now, if such patient dies, this is what you see. This is a real plaque. This artery is completely occluded by thrombus, and the flow in the artery was completely stopped. And this is the angiographic picture of the same thing. This is the artery, coronary artery. You can see here, this is severely narrowed. And can you see this black filling defect here? This black thing is a clot. So this is how a coronary artery of a patient who has acute coronary syndrome looks like. And this is the actual, if you look at the artery, you open the artery longitudinally, and you will see here that there is a plaque here which is ruptured, there is a thrombus on it. So I think in these 4 or 5 cartoons, I could show you, and you probably understood what exactly happens in patients who develop acute coronary syndrome.
Dr. Bhagwan,
Yeah.
your voice is a little bit breaking and echoing. It is not clear. Can you make some changes there if possible?
I will have to check. Just one second.
Because messages are coming in the chat box. The voice is not clearly audible.
I'm in a very quiet room actually. There is no
Maybe the echo is more.
echo. Am I audible now?
Yes, yes.
Hello?
Yeah, audible now.
Is it still echoing a lot?
Yeah, a little bit.
Huh?
Meanwhile, I am happy to inform you that, sir, nearly 213 medical clubs have joined till now. 213.
Yeah. So if you can wait for 5 minutes, I can put my headphones and maybe the echo will be less.
Yes. All participants are requested to kindly wait because of some technical problems, mic adjustment. Please bear with us.
बोलू शकतो तुम्ही नेक्स्ट स्लाइड मध्ये नेक्स्ट स्लाइड दाखवू शकतो तिकडे बोलू शकतो एक रूम मध्ये चला पडतो
स्पीकरमुळे होतं असं तुम्हाला Hello, can you hear us properly now?
Acha, can you hear me now?
Yeah, Bhagwat sir, voice is clear now. One request
Okay, is
was
it?
that, can you make a full screen of this presentation?
Yeah, can you make a full screen?
Okay, yeah, I'll do that.
Sir, your voice is now very good, audible.
Okay.
Yeah.
Okay. Can we start from the beginning, Dr. Deshmukh? Is it okay?
Yeah, briefly, just you can go through.
Okay. Okay. Just go at the beginning. Just go straight to the beginning.
Briefly, we
Go to
can
the first slide.
Yeah.
Okay. I will start my talk, and then in between they can go to the full screen whenever they can do it.
No problem. No problem.
Okay, so let me start with pathophysiology and clinical features and management of acute coronary syndrome. All of you know that acute coronary syndrome is a term which is relatively recent. When I was studying in medical college in late 1970s or the early 1980s, this term was not actually in use. That time in medical colleges, we studied only two terms: acute myocardial infarction and angina pectoris. But then it was slowly realized that even the coronaries, they behave acutely. They can present with acute syndromes like pneumonia or sudden inflammation somewhere. And may I have the next slide? So what is acute coronary syndrome? It's sudden transient interruption of coronary flow related to atherosclerotic plaque. When the coronary blood flow interruption is incomplete, we call it non-ST elevation MI or unstable angina. And when it is complete, we call it ST elevation MI. So now, I would like to make clear that in this particular talk, I am going to focus mainly on unstable angina and non-ST elevation MI, simply because ST elevation MI becomes another topic by itself, and it will take another 1 hour. So this is, I will be talking mainly about unstable angina and incomplete flow, which causes non-ST elevation MI. Next. So this is a cross-section of a artery with a coronary plaque. You can see the yellow structure in the center is the atherosclerotic plaque. The white thing is the lumen, and in between there is a fibrous cap which separates the plaque from the lumen. Now what happens is, in acute coronary syndrome, this fibrous cap which separates the lumen from the plaque gets ruptured. And when it ruptures, the plaque gets exposed to the blood, and then the blood starts coagulating, starts clotting. Next. So the next thing you can see is, you can see that the plaque, the membrane is now ruptured, and the blood has started clotting and encroaching on the lumen. Okay. So this is the angioscopic picture of the same ruptured plaque. You can see that at the center there is a thrombus. Next. Next. Now this is the postmortem specimen of the artery from a patient who had a recent acute coronary syndrome. Again, you can see that there is a plaque from about 4 o'clock to 9 o'clock position, and then at the top there is the artery is completely filled with a thrombus. Next. Now this is the angiographic picture of the same vessel. You can see the coronary artery, which is severely narrowed in the middle, and you can see the black filling defect in the artery. That is the thrombus. Next. Now this is the actual picture of the postmortem specimen, of course, from the artery from a patient who had acute coronary syndrome. You can see that the yellowish background is a plaque which is ruptured, and you can see the blackish structure in the center is a thrombus. Next. So in short, in last few pictures, I was able to show you what happens exactly during acute coronary syndrome. Now, please remember that when patient gets a heart attack, that is ST elevation MI, the pathophysiology is almost the same. The only difference is the thrombus quantity is so much that it occupies the entire lumen of the vessel, and the arterial flow is completely stopped. While in unstable angina or non-ST elevation MI, this interruption in flow is not complete. There is partial antegrade flow, but patient presents with number of symptoms. So what are the features of the clinical features of unstable angina or non-ST elevation MI? Now let me just first make a bit 2 points, 1 point clear. What is the difference between unstable angina and non-ST elevation MI? Basically, the clinical features are same. Everything is same. The ECG features, clinical features are same. The only difference is in non-ST elevation MI, there is evidence of myocardial damage in the form of elevated cardiac biomarkers like troponin or CK-MB. So when you have unstable angina-like presentation with elevated biomarkers, you call it non-ST elevation MI. When there is no elevation of biomarkers, only the patient presents clinically with chest pain. I will talk about it in a few minutes. Then you call it unstable angina. So how do they present clinically? So generally, these patients present with substernal pain. Now, I am not talking here about effort angina. Dr. Palkar will be talking about it later. These are patients which I am talking about at acute coronary syndrome. And in these patients, generally the pain occurs either at rest or with minimal exertion, which the exertion which did not give rise to pain before, now it is producing pain. So the pain is generally substernal. It is either pain or described as heaviness. Sometimes patients, they put fist on the chest. It lasts for minutes or seconds. It radiates. It lasts for minutes, not seconds. So, if the patient tells you that I have a pain or in chest for 2 seconds, generally that is not angina. Generally, anginal pain lasts for few minutes. Can you go to the previous slide? Yeah. When the patient, I'd just like to make a point. There are so many patients we see in our clinic, and they describe their chest pain as chhatit samakali. So I would just like to emphasize that in vast majority of these patients who describe chest pain as samakene, which lasts for a few seconds, is not angina. This is what I have learned over a period of years, that samak is generally musculoskeletal or something else. At the same time, we should not neglect the symptom, but this was just a point. Next. Now, the chest pain can radiate to arm, it can radiate to jaw, it can radiate to back. It is maybe associated with sweating and dyspnea, and sometimes nausea and vomiting. Next. Now, this slide shows you the different parts of the body where the chest pain or anginal pain can radiate. You can see the commonest is substernal, then substernal pain going to neck, left arm, epigastrium, sometimes the necktie presentation, only neck, sometimes only arm and shoulder, or sometimes only back. So we say that patients don't read textbooks. So you must be able to interpret patient symptoms. Sometimes, we read some classical features in textbooks, but patients, describe it in a different way. Patients' perception of pain may be different. So you have to talk to the patient carefully and elicit proper history and make sure whether you're dealing with a patient with angina or not. Next. So, there are 4 types of patients which can be classified as unstable angina. First is worsening angina. Patient, for example, patient had stable angina which used to come only on climbing stairs. This was there for last 1 year. Okay. Now patient comes to you and tells you that now I get pain only after climbing, 3 or 4 steps, not even one staircase. Or he may say that now the pain comes and doesn't go for 10 minutes. It used to go in 2 minutes. Or he may say that, now it is becoming very frequent. So all these features are suggestive of worsening angina. And this indicates that this is unstable angina, the plaque is rupturing, and he is heading towards development of myocardial infarction. Second thing is rest angina. I mean, patient was having effort angina, but now he gets pain even when he's watching TV, or he's just resting, or just eating. Sometimes postprandial angina is also considered as unstable variety of angina. And post-MI angina. Suppose patient developed myocardial infarction, he was thrombolized 2 days ago, and now he was stable and now started getting chest pain again. So all these 4 category of patients can be classified as unstable angina. Next. Now, how do you make the diagnosis? Diagnosis is mainly made based on 3 things. First thing is clinical features, of course, and then that is aided by ECG, echocardiogram, and biomarkers. We'll talk about it. Next, I'll show you some now ECGs of unstable angina. Now, as I said, I'm not talking about ST elevation here, ST elevation MI. There are 3 types of ECGs which I'm showing. The first one is showing ST elevation and T inversion. So that is seen in ST elevation MI. But in non-ST elevation MI, or unstable angina, what you can see is ST segment depression, which is shown in the middle, and T wave inversion, which is shown on the right side. Next. This is one patient with acute coronary syndrome, presents with pain, and look at the ECG. He has marked ST depression from almost V1 to V5, V2 to V5 with T inversion. And please remember that these ECG changes could be very transient. Next. Now here, this is called Wellens syndrome. And this is not uncommon. You can see that in the ECG on the left, in V2 and V3, you can see that there is, the first part of the ST is there, you can see that there is ST elevation, and the terminal part of the T wave is inverted. So this is called a biphasic T wave. And this is again indicative of unstable angina, proximal LAD disease. And on the ECG on the right side, you can see deep symmetrical T wave inversions, which is again indicative of unstable angina. Next. Now, here is one ECG which all must remember. You can see that in all the leads, almost all the leads, you can see ST depression. The ST segment is sagging, it's gone down, okay? Except in AVR, you can see AVR, lead AVR, you can see ST elevation in AVR. So this type of ECG is an ominous kind of an ECG which can suggest a possible left main involvement, the left main coronary artery involvement, which is certainly an emergency. Next. Now, what about biomarkers? You can see that nowadays we don't use CPK or CPK-MB or myoglobin. The most commonly used biomarker today is high sensitivity troponin. Now, this troponin is very specific for heart. Now, there are some other conditions like renal failure or some inflammatory conditions or other cardiac conditions like pulmonary embolism, severe COPD, or cardiomyopathies where troponin can be elevated. But in general, when you have a patient with chest pain, with some degree of ECG changes, and if you see the troponin is elevated, you can be almost always be very sure that you are dealing with a non-ST elevation MI, there is some myocardial necrosis which has occurred and that has released troponin in the blood circulation. You can see that the troponin peaks at about 1 day after the onset of pain, and then it persists in the blood, for up to 1 week after the event. Today's troponin assays are very sensitive, and even a minimal leak of troponin in the blood can be detected by today's very high sensitive assays. Next. Now here I have, in this slide I have put the time frame of elevation and return to baseline of all the biomarkers. And you can see that troponin I and troponin T, they start getting elevated within 2 to 4 hours after the insult. The peak occurs in about 1 to 2 days, and the return to baseline in about 7 to 10 days, maximum couple of weeks. There is hardly any difference between troponin T and troponin I. Both are equally good in making diagnosis. And you can see that within 2 to 4 hours, the biomarkers start getting elevated. And so they are very useful in at least ruling out non-ST elevation MI if it is completely normal for maybe 12 hours after the onset of chest pain. Next. A normal ECG does not rule out acute coronary syndrome. A very important thing to remember. Sometimes patients come to you with very, very typical history. Actually, I just remember a recent patient who came with, syncopal episode. He never had chest pain at all. Elderly man, he became suddenly unconscious. He had syncope. And he went to a hospital, they took an ECG, and on that ECG, they missed, T inversion in inferior leads. There was subtle ST elevation also, which remained for, maybe an hour, and then second ECG was completely normal. And then his troponin was never done. He came to me, and when I looked at it, I did his coronary angiogram, and he had a very, very critical lesion, very severe lesion in his right coronary artery, which was very dominant. So do not totally rely on ECG. History is extremely important. If you believe that this particular patient has, clinically, it looks like angina, unstable angina, do an ECG, but don't depend on it. Even if it is normal, tell the patient that I suspect that your pain is very, very typical and you need further investigation, and you should see, somebody, either a cardiologist or a physician who deals with this. And ECG changes may be completely transient. You may, in unstable angina or non-ST elevation MI, you may get STT changes which remain for some time and they completely disappear within maybe half an hour, 20 minutes. So, and that's why I'm saying that do not get deceived by a normal ECG when the clinical features suggest that patient has unstable angina. Next. Now, what about echo? Now, echo is an important tool for diagnosis, because if you do an echo of the patient who has true unstable angina or non-ST elevation MI, you may, or you're quite likely to see regional wall motion abnormality. Means, suppose patient's left anterior descending is affected, then in that situation, that particular territory, that is anterior wall in the septum, may show hypokinesis, and it's very obvious on echo. Sometimes you see ischemic mitral regurgitation and LV dysfunction. So all these things can be seen on echo, but again remember that it's not a finding where it's not an investigation where findings are always abnormal in this situation. Sometimes echo may have very, very minimal findings, subtle findings, or completely normal echo. So the point which I want to drive home is angina or unstable angina is a clinical diagnosis, which is supported by investigations like biomarkers or ECG or echo. Don't get deceived or fooled by the completely normal findings or ECG or echo if you are convinced that history is of angina. Next. Now, ultimately, every patient of acute coronary syndrome must go to the cath lab. That is true. The question is, what should the physician do at his level before he reaches a cardiologist or a cath lab? Next. Now, what is happening is, when I showed you those slides of thrombus, that thrombus in patients of unstable angina or AC or non-ST elevation MI is made up of platelets and thrombin. And this combination of platelet and thrombin is extremely ugly, because when it forms, it just starts gathering more thrombin, more platelets, and the clot goes on increasing. Next. So let's start with aspirin. This is the first thing which needs to be delivered to these patients. Next. Now, I don't want to go into the details, but these are some clinical trials which were done way back in late 80s and early 90s. And you can see here that when the patients with acute coronary syndrome were given aspirin, their morbidity and mortality reduced substantially. Next. This is the pathway of aspirin, action of aspirin. It prevents conversion of arachidonic acid to thromboxane A2, which produces platelet aggregation. So when you block the enzyme COX-1 by aspirin, what you do is prevent platelet aggregation. Next. So how to give aspirin? First tablet is to be chewed. Okay, that's very simple. Don't ask the patient to swallow it, because when it is chewed, the blood levels go up pretty quickly. If it is enteric coated aspirin, which is swallowed, then the peak occurs after 3 to 4 hours. Once aspirin acts, the platelet is inhibited for its life, with the life of the platelet. Low dose and high dose aspirin has been shown to be equal in its efficiency. So you don't have to give a big dose. Even if you give 75 milligrams of aspirin, that's enough. The gastrointestinal side effects are lower with low dose. There is about 8 to 25% incidence of aspirin resistance in population, but it doesn't matter. Regardless of that, you must give patient aspirin. So all patients of acute coronary syndrome should receive aspirin immediately on diagnosis, and it should be continued lifelong, regardless of the modality of the treatment received. Next. So this is the first thing to be done. Next. Now, what about the other potent antiplatelet agents? One of them is clopidogrel. So if you give patients, you must give patients clopidogrel or some other antiplatelet agent along with aspirin. And that produces much better, much superior effect in terms of platelet inhibition. What you need to do in patients with acute coronary syndrome is to inhibit their platelets. That's very important. So this was the CURE trial, which showed that a combination of aspirin and clopidogrel was superior to aspirin alone. Next. So there are some new antiplatelets now which can replace clopidogrel, and that is ticagrelor and prasugrel. These are the two. You don't know. Previous slide. So when you give ticagrelor, you have to give, it's a 90 milligram tablet. You have to give 2 tablets stat and let's start 1 BD. Or you should give prasugrel, but I would recommend that you should not give patients prasugrel, simply because prasugrel is not the drug which has to be given before coronary angiography is done. So you have choice of either giving clopidogrel or ticagrelor. Next. Next. Now, what about heparin? Now, before you suppose you have no. Yeah. Next. Now, before we talk about heparin, heparin is an extremely effective drug in reducing morbidity and mortality in these patients. There is almost 33% reduction in death and MI, which has been shown in multiple trials, not one trial, almost 6-7 trials, and it has been now its role is firmly established in treatment of acute coronary syndrome. Next. So either you can use unfractionated heparin, that is regular heparin, or low molecular weight heparin. Both are good. If you give unfractionated heparin, actually nobody uses unfractionated heparin these days because at most places, even at small places, low molecular weight heparins are available. So when you give unfractionated heparin, give about 7,500 to 10,000 units bolus, followed by 1,000 units per hour infusion. Check PTT after 6 hours, and your target PTT should be 60 to 75. So you titrate your rate according to the PTT. There are standard nomograms for dose adjustment. You can use them. Next. We'll talk about low molecular weight heparin, which are very easy to give. You don't have to monitor their effect. Their effect is very predictable. This was the original study with dalteparin. We don't have dalteparin in the market now. Next. All the low molecular weight heparins like dalteparin or enoxaparin, all these have been shown to be very, very useful and equally useful in treatment of acute coronary syndrome. They are as good as regular unfractionated heparins. Next. And you can see here that you can compare low molecular weight heparin versus unfractionated heparin. Low molecular weight heparins are consistently superior to unfractionated heparin. So if given a choice, you should always use low molecular weight heparin simply because their action is very predictable, their effect is predictable, you don't have to monitor it, so you are not likely to make any mistake in anticoagulating the patient in cases of acute coronary syndrome. Next. It does not bind to plasma proteins. Low molecular weight heparins don't bind to plasma proteins. Therefore, their bioavailability is very predictable. And their dose response curve is very, very steady. Very easy to administer. They have to be administered subcutaneously. There is no laboratory monitoring required. Many times, first dose of low molecular weight heparin is given IV, and then subsequently you give subcutaneous dosing. Next. So this is what we have done so far. We have given the patient aspirin, which is to be chewed, followed by 1 OD, then either clopidogrel or ticagrelor, and then low molecular weight heparin. Now, if low molecular weight heparin is not available for any reason, then only you can use regular heparin. Next. Now, what about 2B3 antagonists? Now, these are some new drugs which are used by cardiologists and physicians, but these days, because of better antiplatelet agents, their use has been substantially reduced. In old days, 10 years ago, their use was much more common. Before shipping the patient to a hospital with a cath lab, patients used to be loaded with antiplatelet drugs, heparin, and sometimes they used to be on 2B3 antagonist drip like tirofiban or eptifibatide. I don't want to go into the detail of 2B3 antagonists simply because it is not really recommended these days. But sometimes what happens is, if the patient has ongoing chest pain, you have given him everything, and say the cath lab is say 5-6 hours away by road, then it may be worth starting this patient on a 2B3 antagonist drip and send the patient to a higher center. Next. This is again the graph showing the utility of 2B3 antagonists in patients with ACS. Next. You can go to the next slide. Same thing. Now, this is the final prescription: aspirin, clopidogrel, low molecular weight heparin, and if needed, integralin or tirofiban infusion. if the cath lab is far away. Next. As I mentioned, the use of 2B3 antagonists has gone down substantially due to better antiplatelet drugs and better stents. Next. So, in conclusion, I would like to say that antithrombotic therapy forms the cornerstone in the treatment of acute coronary syndrome. Aspirin should be started immediately and continued lifelong. Clopidogrel or ticagrelor should be started preferably with a loading dose and continued for at least 9 months to a year. And depending on whether the patient had angioplasty, how many stents were put, how are his arteries looking, depending on other things, the cardiologists generally take decision about the duration of dual antiplatelet therapy. Next. Low molecular weight heparin should be started immediately and continued for at least a week or till the patient undergoes angioplasty. 2B3 antagonists may be started if you are pushed against the wall. IV thrombolytic therapy and oral 2B3 antagonists have no role in treatment of non-ST elevation MI. So this point I would like to make, that patients, regardless of severity of chest pain or clinical presentation, if there is no ST elevation on ECG, there is no reason or indication to give thrombolytic therapy. Thrombolytic therapy is given only for patients who have ST elevation on their ECG. For all other patients, they have to be managed in the way I just described in last 20 minutes. Next. Immediate triage to high-risk patients, particularly those with marked ECG changes and marked troponin elevation, they should be sent for intervention with or without pre-treatment with 2B3 antagonists. As I mentioned, these days the role has reduced and there is no definite recommendation about it. Next. So this was, in short, my talk about management of acute coronary syndromes, which includes unstable angina and non-ST elevation MI. I thank you all for your patient hearing, and I don't know whether they're going to take questions right now or what. Dr. Deshmukh will take that call.
Yes, thank you, Dr. Babu sir. There are a few questions are there. I don't know, you are ready to state in the end of the webinar, or should I take your questions, your topic related questions right now?
You can take, it will be better if you take it now, because then, yeah. And if there are some more questions, you can just give me a phone call, I will join again.
Okay. Now there are 2-3 questions are there. First is you not mentioned or may have forgotten of the dose of the low molecular weight heparin.
Well, dose of the low molecular heparin, now it depends on which low molecular weight heparin you use. If you use enoxaparin, which is the most commonly used low molecular weight heparin, the dose is generally weight related, but the standard dose for a 60 kilo patient is 0.6 ml subcutaneously twice a day. Now, if the patient weighs more than around 100 plus, then you can give up to 0.8 twice a day. And you must remember that the dose of heparin has to be adjusted according to the renal function of the patient. So if the patient's creatinine is elevated, you have to adjust the dose according to it.
Okay. So second question was, what are the treatment options in aspirin allergic patients?
Yeah, see, the problem is that it's not easy to diagnose aspirin. You mean aspirin resistant patient or allergic patients?
Resistant.
You said allergic patient, right?
Yeah. Is there any entity like aspirin allergic patient?
Yeah, see, the thing is, aspirin allergy is not very common. I mean, if the patient tells you that he definitely has aspirin allergy, some patients do have it, and they develop severe bronchospasm, features of asthma.
Yeah.
So if there is a definite history of aspirin allergy, then use clopidogrel, in a very in the standard dose. If the question is whether the history of aspirin allergy is reliable. Many patients tell us that I am allergic to aspirin, and I've seen that, almost in all patients, nothing happens when you give them aspirin. Sometimes they call, if they get some itching because of aspirin, they will call it it's allergy. But if patient tells you that I am allergic to aspirin, just go into the detail of the history and ask him, how often have you taken aspirin? What was the problem? If it is consistent, like it has happened 2 or 3 times, and particularly if it is associated with bronchospasm, then you have to take it seriously. But I'll tell you seriously, in my practice of last 30 years, I've rarely seen a patient with severe aspirin allergy.
Okay. And even if it is there, then any alternative for the aspirin?
Well, you can use clopidogrel.
Okay.
Nowadays, you have ticagrelor, which is a very, very potent antiplatelet agent. And, in this case, you will have to manage this patient with single antiplatelet rather than dual antiplatelet. These agents are more potent than aspirin.
Sir, one of my medical officer asked another question. Can ECG be completely normal and the echo showing RWMA in unstable angina?
Yes, it can. ECG can be completely normal, and echo is a very sensitive test. See, what happens is, I will tell you. Suppose you occlude a coronary artery in a human being or rabbit. What is the first thing that happens? If you clamp the coronary artery, the first thing that happens is, in that area, diastolic dysfunction appears first. Relaxation is affected first. The next thing that happens is systolic function affection, that is regional wall motion abnormality. The third thing that happens is the ECG abnormality. And many times chest pain occurs as the last thing. So this is what is seen in experimental animals. It doesn't necessarily happen in human beings in the same sequence all the time. But generally, this is the sequence. So many times patients can have typical ongoing chest pain. ECG is normal or maybe showing some subtle changes. But if you do a good echo, it can show you regional wall motion abnormality. And we see it quite often. It's not, the important thing is you should have a good echocardiographer, a good machine, and you should be able to do the test when the patient is having ongoing chest pain. If the patient has no chest pain, the echo is likely to be normal.
So the next question is that the role of the statin in the acute coronary syndrome.
Yeah, actually, I should have mentioned it. I did not mention it in my talk, but it's a recommendation. You should give high dose statin, not 10 milligram or 20 milligram, at least 40 milligrams of atorvastatin or rosuvastatin at the onset of chest pain if the diagnosis is confirmed. So actually, that is true even with ST elevation MR. There is some data to suggest that it helps. The data is not overwhelming, but at the same time, there is data to suggest that it helps.
Okay. The typical public health department question is that any screening test set, you would recommend for asymptomatic population.
Screening test?
For asymptomatic population.
See, asymptomatic population is a very general term. Now, I will give you an example. A patient comes to you he's completely asymptomatic, but he tells he's obese, he smokes 2 packs of cigarettes a day, he has got a very bad family history, in terms of deaths, cardiac deaths at young age, and say his cholesterol is high. Now, this is one patient. And then you have another patient who doesn't have anything of this. He's non-obese, he's in his 40s, he exercises regularly. The question is, these two asymptomatic patients are not the same. So basically, asymptomatic patient is a generic term. You have to get into the details of the history and then decide whether that particular patient needs any further investigations or not. If the patient has multiple risk factors, you can make out from his lifestyle and his basic, body weight, blood pressure, blood sugars, and you can see that he is sitting on a time bomb. it's very important that he undergoes some kind of screening test. And if such a patient has to undergo a screening test, a exercise treadmill test is a good way to begin. But don't categorize all asymptomatic patients under one umbrella. They can be very, very different.
Another question is that, should we give the 80 milligram atorvastatin with the aspirin or not?
With what?
Atorvastatin, ATOR.
Yeah. With to ACS patients?
Yeah.
Yeah, I've just mentioned it that there is a recommendation that you should give such patients high dose statin as the first dose, and that is at least 40 milligrams of atorvastatin or rosuvastatin. High dose atorva is 80 milligrams actually, but you should give at least 40.
And this statin should be continued lifelong?
Well, it depends on what he turns out to have. If the patient, you have given him, say, patient has chest pain, you have suspected acute coronary syndrome, you have given him 80 milligrams atorvastatin, and then he undergoes angiography, and suppose he undergoes bypass or angioplasty, whatever. If he turns out to have documented coronary artery disease, then statin is almost always lifelong. Its dose may vary depending on his lipid levels and his lifestyle modification, but the statin continuation is lifelong.
Sir, another question is that, if there is any bleeding disorder along with the ACS, how to manage it?
Well, bleeding disorder, which I need to know what kind of bleeding disorder. I mean, it's a very loose term. Are you talking about something serious like hemophilia or some kind of a clotting disorder, serious clotting disorder, or sometimes these are loosely used terms. But if patient has some serious bleeding disorder, then in that case you'll have to take a hematology consult and then plan the treatment accordingly. In such patients, you may not be able to give these patients heparin or antiplatelet agents. But it's a very, very broad question. It depends on what kind of coagulation disorder you are talking about, or bleeding disorder you are talking about.
The next question is role of the nitrates in the immediate management when the tertiary center is 3-4 hours away. Role of the nitrates.
Yeah, nitrates should be given for symptomatic treatment. If the patient has ongoing chest pain, you must give nitrate. They are very, very useful. You can give sublingual nitrate, or to begin with, if the patient doesn't, the pain doesn't subside, you can give intravenous nitroglycerin drip, and the dose is from 20 micrograms to 200 micrograms, and you can titrate nitrates to chest pain and blood pressure. But see, pain management in acute coronary syndrome, in Western countries, you use nitrates and they give a lot of morphine. Now, we don't have morphine in our generally in our hospitals, but I think the most useful drug for us in such patients is nitrates.
What about the term prophylactic angiography? And when we do it?
Prophylactic? No, there is nothing like prophylactic angiography. Because I don't know what do you mean by prophylactic angiography.
Please mute the mic.
Informative Because of that.
I think
yeah, continue, sir.
Yes. Any other question?
Okay. Role and the dose of the sublingual nitrates in the immediate management when the tertiary center is I have answered it now.
See, nitrates have a role in chronic stable angina, in unstable angina also. If you want to give sublingual nitrate, you can use either a spray or our isosorbate dinitrate tablets, sorbitrate to be kept under the tongue. Now, generally, what is advisable is you keep one tablet of 0.25 milligrams or 0.5 milligrams sublingually, wait for 5 minutes. If the pain doesn't disappear, you can put one more under the tongue, or even spray it under the tongue or on the buccal mucosa. And generally, after 2 doses, if it doesn't subside, there is no point in repeating it, because then in that case, you will just drop the patient's blood pressure without helping him much.
Then what is the alternative drug in that case?
For to nitrates?
Yeah.
Well, actually, in such patient, morphine is a very good drug, but it's not available.
No, the precondition is that that tertiary center is 4 hours away, and you have to travel.
No, in that case, if you want to sedate the patient,
Okay.
basically, sorbitrate will reduce the pain. But then, if you want to sedate another thing which you can do in this situation is use intravenous beta blockers. Now, I did not go into that detail because sometimes these patients have blood pressure which is on the higher side and they have tachycardia. And in that situation, you can always use intravenous beta blockers like metoprolol. Giving 5 milligrams of metoprolol in this patient helps to bring down the heart rate and blood pressure, and that will reduce angina also very dramatically. So I think beta blockers and nitrates are good drugs. If they don't work, and if morphine is not available, then you can use our routine Fortwin Finargan combination for sedating the patient. But in our cath lab, when the patients get chest pain while doing angioplasty, we use sometimes fentanyl, 50 to 100 milligrams, or midazolam in small dose to sedate these patients.
Okay.
So to make the answer short, if nitrates, beta blockers, and sedation.
Right. Can we give the ecosprin more than 300 milligram in ACS?
No, you can give it, but you don't have to give it, because as I told you, the dose, the aspirin dose, there is no difference between 75 milligrams and 300 milligrams in terms of platelet inhibition. But there is certainly a difference in incidence of bleeding when you use higher doses. So it's always better to use a small dose, not more than 75 to 150 milligrams.
Okay. And if the patient is having a duodenal ulcer in this, along with the coronary artery syndrome, can we give the aspirin or any alternative?
Yeah. See, unless the patient has history of active bleeding recently from an ulcer, documented, then only this problem will arise. Most often, if there is history of duodenal ulcer, and if you give one tablet of aspirin, it's not going to hurt the patient. But the benefit of giving aspirin in these patients is going to be much more than the harm that you can produce. The only problem is if you have a recent history of bleeding from a duodenal ulcer documented, then in that case, you will have to just take a GI opinion and then, try to use certain other, injectable antiplatelet, tirofiban, these kind of drugs. But just having history of duodenal ulcer may not be a contraindication to give aspirin. Sometimes, a patient may have history of duodenal ulcers 6 months ago, 1 year ago, and it has now healed. Most probably it heals within 6 to 8 weeks, 2 months, if you treat it properly.
Sir, there is one question, a little bit lengthier one. In remote area, if we diagnose the ST elevation MI with the help of ECG only, will take 2 to 3 hours to reach the tertiary faculty. Can we give the heparin instead of STK or any other thrombolytic agent? Can we give the heparin in that case?
But see, if you have thrombolytic agents, why not give it? If you have thrombolytic agent, give it. If you don't have thrombolytic agent, then heparin is a weak second choice. Is a very weak second choice. So, are you trying to ask me that in remote place streptokinase is not available Are you considering that situation?
Yes.
If streptokinase is not available, and if you have a patient on ST elevation MI, then the first thing you do is give him aspirin. Give him chewable aspirin as a first thing, and then of course you can put him on heparin and shift him as quickly as possible, because thrombolytic agent is the most important thing here, which you don't have.
There are two questions where your answer is required. One is what is the best drug for thrombolysis in AMI according to your opinion, and secondly,
I didn't hear the question. Can you repeat it?
Yeah. What is the best drug for thrombolysis in your opinion?
What is the best drug?
Huh.
Best drug for thrombolysis?
Yes.
Okay. Now, there are 2-3 things which are to be considered here. First is efficacy, second is safety, and third is the cost.
Okay.
Right? These are the 3 things. Now, if you look at the cost of the drug, the cheapest drug today is streptokinase. Okay.
Yeah.
Now, the difference in the cost of streptokinase versus TPA is huge difference. Streptokinase you can get in 3,000-4,000 rupees, while TPA still costs you minimum about 30,000 to 40,000 rupees. So 10 times. Now, in terms of efficacy, the difference in efficacy is not 10 times. Our good old streptokinase is maybe slightly inferior to TPA in opening the artery. The difference is not huge, but the benefit of TPA is, number one, it can be given as a bolus, while streptokinase has to be given as infusion. So during infusion, you can have rigors, you can have reactions, you can have hypotension, and it gives you very, very nervous movements when you're giving the patient streptokinase. But TPA is very easy to give. It's just bolus. Just give a bolus and forget about it. And in terms of bleeding, serious bleeds can occur with both streptokinase and TPA. So I would, in a country like India, I would still not write off streptokinase as a very important drug. But suppose patient is affording, you have both the drugs available, when patient is in front of you, TPA may score a little bit more over streptokinase.
With a 10 times cost.
With a 10 times cost, that's right.
Sir, there is a particular question to you. Your remark on the MI occurring in young adults. Any changes and your comments?
Sir, repeat. Can you repeat it?
Yeah, your remark on the MI occurring in young adults.
Yeah. Now, actually,
management part and your remarks.
Actually, we are deviating from the topic, but at the same time, this discussion may never end. But when you get into the coronary artery disease in young individuals, the people have hundreds of questions. But you are right. I mean, these days we are seeing young patients with MIs. Yesterday, you must have heard that one very famous actor from stage, Marathi stage, Shreyas Talapade. Yeah, at the age of 47, had an acute myocardial infarction. And he was treated in Mumbai with an emergency angioplasty. So these things are happening. I think stress and improper lifestyle are the 2 most important reasons for this. Of course, other risk factors like smoking, diabetes, hypertension are there. But in young individuals, you see these heart attacks even without any risk factor. So I think stress is producing a big role in producing acute coronary events in young individuals these days. There is no question about it. So, following proper lifestyle is the key to avoid heart attacks at a young age. Actually, on 29th of September, last September, that was World Heart Day, I had made a small clip on lifestyle and heart attacks. And I think lifestyle is becoming the key word in preventing heart disease.
It is a video film.
It is what?
It is a video film. Audio visual.
Yeah. It's a video film. Yeah, I will send it to you. You can send it across.
No. If it possible, we can play at the end of this webinar also. If possible.
Yeah, let me see if I can do it right now. Maybe what you can do is I will give it to my colleague and he will play it later. You can switch to the next speaker because it's already 3:45.
Yeah.
And I will find out that clip and I will put it on later. If it is okay with you.
One last question for you.
Yeah.
Last question. Please specify about the management of endothelial dysfunction.
No, see this. Yeah. Actually, endothelial dysfunction is the first thing that occurs before atherosclerosis begins.
Yeah.
So endothelial dysfunction cannot be seen with your eyes. I have seen some people reporting endothelial dysfunction on coronary angiogram, which is a terrible mistake to make. You cannot diagnose endothelial dysfunction on coronary angiogram or anything. Coronary endothelial dysfunction is a thing which occurs microscopically. You cannot see it with your eyes. But of course, it's a precursor of atherosclerosis. And if you are not following good lifestyle, if you are smoking, if you have diabetes, if you have hypertension, which is untreated, you can assume that you have endothelial dysfunction, even if there is no plaque in your coronary artery. So why do you need to document it? You can know it if you can know it, your patient has it if he's not following your lifestyle advice. So endothelial dysfunction prevention is the key, and the answer lies in your lifestyle. Your good lifestyle, and if you have risk factors, control them properly.
Okay, sir. There are still questions are going on, but I know that you are busy in your routine activity. I will do one thing. I will just send you questions, and if time permits, you can join at the end of the day, or send the answer of that. I will read it out on your behalf. Yeah,
sure. We can do that. I have actually a case lined up right now, and you can go ahead with my colleague, Dr. Ranjit Palkar.
Yes.
And in the meanwhile, if I can get that video, I will send it to you.
Okay. Thank you. Thank you very much.
Thank you. Thanks a lot, Dr. Deshmukh. Thanks everyone for your patient hearing.
Thank you. Now moving to the next part. Before that, moving to the next part, I welcome Dr. Savita Hazare, who is the Deputy Director, recently joined in the NCD cell. Dr. Hazare ma'am is there? Dr. Hazare, Savita Hazare ma'am?
Yes, sir.
Yes, you are welcome on the board.
Yes, sir. Thank you, sir. Good afternoon, everybody.
Yeah. Would you like to express something about the NCD and coronary disease for our viewers and medical officers across the Maharashtra?
Yes, sir.
Yeah, please continue. In brief.
सर मी मराठीत बोलते सगळ्यांना समजायला.
Yes.
सर आपल्याकडे आपण कोरोनरी आर्टरी डिसीज साठी आपण स्टेमी प्रोजेक्ट राबवतोय. आपल्याकडे सध्या आपण 12 जिल्ह्यामध्ये स्टेमी प्रोजेक्ट राबवतोय. तो हब आणि स्पोक्स मॉडेल मध्ये आहे. जवळपास आपल्याकडे 38 हब आहेत आणि 145 स्पोक्स आहेत. आणि आता आपण काही दिवसातच आपण पुन्हा बाकी सर्व जिल्ह्यासाठी 22 जिल्ह्यासाठी आपण हब अँड स्पोक्स मॉडेल मध्ये स्टेमी प्रोजेक्ट राबवणार आहोत. याचा अर्थ असा आहे की प्रत्येक पीएससी म्हणजे आता आपल्याकडे जे 1908 पीएससी आहेत आणि उरलेले 220 RH SDH आणि वुमन्स हॉस्पिटल आणि डिस्ट्रिक्ट हॉस्पिटल्स आहेत. याच्यामध्ये आपण हा प्रोजेक्ट राबवणार आहोत. उरलेल्या म्हणजे आपण टोटल महाराष्ट्रामध्ये हा स्टेमी प्रोजेक्ट राबवणार आहोत. याचा अर्थ असा आहे की प्रत्येक पीएससी ला, प्रत्येक सीएससी, RH SDH, वुमन्स हॉस्पिटलला आपली एक ईसीजी मशीन असणार आहे आणि तिथे क्लाउडवर तुमचं रेकॉर्ड होणार आहे आणि विदिन 10 minutes यू विल गेट द रिपोर्ट ऑफ द ईसीजी की वेदर इट इज अ स्टेमी ईसीजी और नॉट, वेदर इट इज अ नॉर्मल or you have some other heart disease or ST elevation myocardial infarction. तर हे आपल्याला त्वरित कळणार आहे विदिन 10 minutes. तर म्हणजे सर आतापर्यंतचा रिपोर्ट असा आहे की विदिन 5 minutes वी आर गेटिंग द रिपोर्ट अँड वी आर अंडरस्टँडिंग की ह्या पेशंटला हार्ट अटॅक आहे की नाही. तर सर्व पीएससी लेवल, सीएससी लेवलचे सगळे आपले मेडिकल ऑफिसर तेव्हाच्या तेव्हा ओळखू शकणार आहे की या पेशंटला हा त्रास आहे आणि ते त्वरित त्याचं नोटिफिकेशन करून त्याला त्वरित आपण हबला पाठवणार आहोत. हब म्हणजे तुमच्या एरियातील MJ-PJY रिकॉग्नाइज कॅथलॅब असलेले कार्डिओलॉजिस्ट असलेले जे स्टेशन्स आहेत किंवा मेडिकल कॉलेजेस आहेत, हे किंवा काही खाजगी रुग्णालय किंवा धर्मादायचे जे रुग्णालय आहे जिथे कॅथलॅब आहे, जिथे समोर आपल्याला अँजिओग्राफी अँजिओप्लास्टी आपण करू शकतो, असे जे रिकॉग्नाइज आपल्याकडे जे हे सर हॉस्पिटल्स, त्यांना आपण हब घोषित केलेला आहे आणि त्या सगळ्यांचा फायदा आपल्या पेशंटला होईल या दृष्टिकोनातून आपण समोर काम करत आहोत सर. आतापर्यंत 12 जिल्हे झाले. आता समोरचे जिल्हे काही फ्यू मंथ्स मध्ये सध्या प्रोसिजर सुरू आहे सर आणि ते होऊन जाणार आणि सगळ्यांना आपल्याला या गोष्टीचा फायदा मिळणार. त्याच्यामुळे आजचे जे आपले व्याख्याते आहेत ते खूप छान माहिती देत आहे, जेणेकरून जर तुमच्याकडे कुठलाही चेस्ट पेनचा पेशंट आला तर तुम्ही त्यांना त्वरित रिस्पॉन्ड करू शकता, तुम्ही त्यांना त्वरित उपाय करू शकता. की आपण सगळं ट्रेनिंग घेत आहोत. तर सर्वांनी याचा लाभ घ्यावा आणि जे काही तुमच्याकडे ECGचे आता आपण जे स्टेमी प्रोजेक्ट आपण राबवणार आहोत, त्याच्यामध्ये ज्यांच्याकडे नवीन येणार आहे त्या सर्वांचं काय करायचं आहे याच्यासाठी डॉक्टरांचं सिस्टरांचं ट्रेनिंग पण होणार आहे. तर सर, दिस इज व्हेरी नाईस टू हॅव दिस वेबिनार आणि एवढे रिकॉग्नाइज कार्डिओलॉजिस्ट आपल्याला उपलब्ध झालेत सर आणि वी आर गेटिंग अ नाईस नॉलेज फ्रॉम देम आणि हे खूप चांगली गोष्ट केली सर तुम्ही आणि थँक्यू फ्रॉम NCD अँड फ्रॉम JD NCD sir also. He's with some some urgent reason he's out.
On behalf of you, I am working for the NCD because
Yes,
SCRC
sir.
is not a separate entity. He just supports
Yes,
a
sir.
body for research management and evaluation purposes.
Yes, sir.
Thank you, ma'am. And I am very
Thank
sorry,
you, sir.
Dr. Ranjit Palkar, I have kept you waiting.
No, not at all, sir.
Yeah. So moving to the next part, with the kind permission of Dr. Hazare, ma'am.
Yes, sir. Yes, sir.
Yeah. Our next topic is the diagnosis and management of the chronic coronary artery syndrome or a disease. Our eminent speaker now is Dr. Ranjit Palkar. I will briefly introduce Dr. Palkar, who is MD Medicine and DNB Cardiology, working as a consultant interventional cardiologist at the Kamal Nayan Bajaj Hospital from last 5 years. Underwent the DNB cardiology training at the prestigious Madras Medical Mission, Chennai. Has keen interest in the medical research and sub-principal investigator in the Emperor and the Select clinical trials. He has a number of publications in the index journals under his belt. This is a brief introduction about Dr. Palkar sir. Now I request Dr. Ranjit Palkar sir to kindly start your presentation, and at the end of presentation, do answer our questions asked by the medical officers.
Yes. So thank you very much, sir, for that nice introduction. I think I will just share my presentation first. So, is my presentation visible?
Yeah, it is visible, but make it a full screen, sir.
Yes, I'll do that. Yeah.
Yeah.
So, good afternoon all. After Bhagwat sir's very much informative lecture, I think all of you must be quite tired of hearing this term. But I think it is very important that we keep learning. We know how the new changes that has been happening in this particular era, where we all need to know where there are some changes as we so most important thing is as we learn in science, we always know that there are many things that keep on changing, that keep on updating, and this is something that the new topic that has come up, and we all know this is just because of our knowledge that we could get into the terminology that we are talking about, but especially after the EST and the ACC AHA bodies, they have been formed. they are continuously upgrading our knowledge. And I think today's platform by Deshmukh sir is definitely very much important to upgrade all the medical officers, because once we started using or conducting such programs like STEMI, that is in Maharashtra, I would like to just mention about that. My parent institute, Madras Medical Mission, Chennai, was one of the pioneer institute to start this particular program in Chennai, Tamil Nadu. So it was called as TN STEMI program, and that was the first program that was started by Dr. Ajit Mullasiri and Dr. Thomas Alexander. And I think from there we definitely learned many things, and the same program is being utilized in most of our states to revolutionize the medical treatment. So we'll start with introduction. See, basically most of my job is done by sir, and I would like to anyways refresh few of the things and then go to my particular topic. So what basically coronary artery disease means? So it is nothing but it is the most common cause of angina, as we all know. It is nothing a pathological process where it is characterized by atherosclerotic plaques that accumulate in epicardial arteries, whether they're obstructive or non-obstructive. So anything, even if it is significant obstruction or it is not a significant obstruction, we would call that particular artery to be diseased. Why ischemic heart disease is something wherein the condition where there is an inadequate blood supply, which leads to the inadequate supply of oxygen to a portion of myocardium that is associated with disturbance in myocardial function. The term occult CAD is common in those who present with other forms of atherosclerotic vascular disease, such as intermittent claudication or stroke. So you have different groups of patients now. We are going to see these definitions, and we are going to understand why this particular terminology has been invented. So coronary artery disease is one terminology. Second is ischemic heart disease, where there is inadequate supply of the blood. So anatomical disease, coronary artery disease. Physiological manifestation of that leading to supply break or reduction of blood and oxygen both to a myocardial area will be called as ischemic heart disease. And some patients who don't have any symptoms for heart, say somebody is not having angina, somebody is not having dyspnea, and he actually is presenting with some intermittent claudication, so he has a peripheral vascular disease, or he is presenting with stroke, and now you do his coronary angiography and you find out that there is some coronary artery disease, that is nothing but an occult CAD. So this is a pool of patients now we generally see, wherein the patients have coronary artery disease. So this is a large pool. Few of them have, because of that obstructed coronary arteries, a decreased blood supply to a particular area of heart, and that leads to myocardial dysfunction. And this group forms an ischemic heart disease group. While there are patients who continue to have ischemic symptoms even at rest. So we may call them to have an unstable angina, or there are patients who have it during exercise, and then we call it a stable angina. So what we have previously was there are different groups that have been put in the patients who have ischemic heart disease. One group was called as those having acute coronary syndrome that we already discussed. Then next is the chronic stable angina, and then the third term was sudden cardiac death. But what we now have is acute coronary syndrome as a one group and chronic coronary syndrome as a second group. And this is something which was formed after the ESC meeting that was conducted in 2019, which actually made us to understand what chronic coronary syndrome is. So as we all know, in 1772, William Habermas described angina initially, and he actually thought it is a disorder of breast. But later, then the Royal College of Physicians in London named it as angina pectoris. So angina pectoris is nothing but a symptom complex, which is caused by transient myocardial ischemia, which occurs whenever there is an imbalance between myocardial oxygen supply and demand. So this is how a natural history of a chronic coronary syndrome patient looks. So there are now patients who have had an acute coronary syndrome in past. Now this patient has either been diagnosed and then put on medications, or he undergoes a revascularization procedure. Now what happens is you have three different pathways now in this particular diagram, where the patient from an initial subclinical phase to diagnosis either have some medications or gets revascularized. And then later on, if he continues to lower his risk factors optimally with controlled risk factors, like say if he does lifestyle changes, he continues on adequate therapy, he continues medications for secondary prevention and does an appropriate revascularization, he just have a very normal course and there are no bumps in between. So he enjoys his routine life. Then you have a group of patient where patient have had an ACS in past. Now he was having his things were quite okay, but suddenly because of some insufficiency in risk factor control, suboptimal lifestyle modification, and some lag in medical therapy, he again has an ACS and later undergoes either revascularization or some therapy change, or maybe revascularization in the form of either PCI or CABG, and then he continues his routine life. The third group is the patient have had an ACS in past, but then again has an ACS in near future, continues to have the insufficiently controlled risk factors, the suboptimal lifestyle modifications, and some drug non-compliance, which makes him to have recurrent ACS. Such patients keep on coming to the hospital, they get hospitalized, they get revascularized again and again. So they underwent PCI initially, may require CABG again, or may require even some kind of other therapies in their lifetime. So this is how a patient with chronic coronary syndrome will behave. So generally, we need to know what this particular group is and how often they are going to. So in past, what we had was the patient was having a group. Patient was having an ACS. Now, because of his because of his natural history, the patient is getting into a recurrent acute coronary syndrome events, but then he continues to have a stable disease later on. And such patients are actually were previously labeled as stable coronary artery disease. So now 2019 ESC has replaced the particular term of stable CAD by something called as chronic coronary syndrome. This implies that the coronary artery disease is a dynamic process, and the clinical presentation of which can be either acute or chronic. So let's learn about how does a chronic coronary syndrome patient will come to you. So in your routine practice, generally what we have is the patient who have a chronic coronary syndrome, either he is a suspected chronic coronary syndrome or an established chronic coronary syndrome. So there are almost 6 different scenarios how the patient will come to your outpatient department. First scenario is a patient who had suspected coronary artery disease, had a stable angina symptoms or dyspnea. So this is a routine patient where you are sitting in an outpatient department, patient comes, he is being observed or being evaluated by some of the physicians outside. Patient has some exertional symptoms. So patient walks, gets angina, or he walks, gets dyspnea, and then he is reported to you to have some kind of suspected coronary disease. You further evaluate the patient and find that this patient has coronary disease. Second scenario is a patient who had never had any kind of symptoms in the past. Suddenly he has presented to your emergency department, and the patient has presented with symptoms of sudden onset left ventricular failure. So generally this patient has some very much accelerated hypertension, or they complained of having worsening dyspnea in recent past. Then you do their 2D echo, and then you find out there is some LV dysfunction too. So either of these can also be a subset of group who has chronic coronary syndrome, and now the patient comes under a suspected category of coronary disease. The third scenario can be an asymptomatic and asymptomatic. So both, either asymptomatic or a symptomatic patient who has had an ACS almost an year back or less than a year back. And now this particular patient is following up for further visits. So he can be either asymptomatic or symptomatic. He has had an ACS, now he is coming to a routine OPD. He had some revascularization in past, or he was just told that his myocardial infarction was treated with medications and angiography is okay, he has been asked to continue on medical therapy. So he can be in any of these categories. The fourth scenario can be a patient who is either again asymptomatic or symptomatic, but then his initial diagnosis of ischemic heart disease or the coronary disease has been done more than 1 year, and the respiration also has been done more than 1 year. The fifth scenario is a patient who had an angina and he's rather suspected to have a vasospastic or microvascular disease type of angina. So these are the patients where the epicardial coronary arteries looks quite normal. There is no coronary disease as you see on coronary angiography, but then patients continues to have an angina, and these patients are typically either have a vasospastic angina or something called as microvascular angina. Microvascular angina is again something more common in patients with diabetes mellitus, wherein a small vessel disease is again very commonly seen. Then you have sixth group of patients wherein a patient is asymptomatic completely and whom the coronary disease is just detected at screening. So somebody is just normal, doing his normal activities, he comes to your department, wants to have a routine health checkup, you do his screening test, you do his treadmill test, you find that he's a candidate to have coronary disease, and you suggest him doing some further testing. So these are the 6 different scenarios wherein a patient will come to you, and he will definitely fit into any of these 6 categories that most commonly are seen. So out of these 6 scenarios, if anything is seen, you can label that particular patient to have a chronic coronary syndrome. I think this slide is definitely quite a busy slide, but that very, very important too. So what is the pathophysiology of this chronic coronary syndrome? So as we know that anybody who had an acute coronary syndrome, who had some kind of the coronary disease, deals with having an insufficient blood flow. I think sir has already shown us how patients develop atherosclerotic plaque. So similar way, you have a narrowing of coronary because of this atherosclerotic plaque. Then you have insufficient blood flow that leads to myocardial oxygen demand, and which actually exceeds the supply. The anaerobic metabolism with lactic acid accumulation, myocardial nerve fibers, they get irritated. The pain message is transmitted to the cardiac nerves and upper posterior nerve root, and this leads to have an angina. What is the etiology of this particular element? So most of the cases, it is the atheroma. That is almost 90% of the patients will have atheromatous coronary disease as the cause of such particular chronic coronary syndrome. But then there are cases where patients tend to have some congenital heart disease, some valvular heart disease, even accelerated uncontrolled hypertension is cause for angina, cardiomyopathies, vasculitis, anemia, and thyroid process. So these are the few different entities wherein patients can have chest pain, and these can be put under the chronic coronary syndrome umbrella. So what are the congenital diseases that can have chest pain? So there are few of the congenital heart disease wherein patients, because of the stretching of some pulmonary arteries, they may complain of chest pain. Then because of some decreased oxygen supply, or especially to the RV myocardium, some of the patients with congenital heart disease can have chest pain. Valvular heart disease patients, especially those with the severe aortic stenosis, can have chest pain. So it is very common in such patients, especially if you have the AR, severe valvular aortic regurgitation. Such patients can report having the nocturnal angina, sometimes called as even the decubitus type of angina when they lie down in night. Then you have uncontrolled hypertension leading to LVH and increased myocardial demand, which is not optimally given by these coronary artery flows, and that can lead to have some patients to have chest pain. Cardiomyopathies like the HOCM, again, that comes as a genetic disorder. Such patients can present with angina. Vasculitis and aortitis definitely can cause coronary narrowing, and say Takayasuga arteritis can have the patients to have such kind of the narrowing, and they can lead to angina. Anemia per se increases your symptoms mostly because of just an reduction or inadequate supply-demand mismatch of the oxygen to the myocardium, as it can cause everywhere in your body. And then finally, the thyrotoxicosis herein against the increased heart rate and that leads to the increased demand, which leads to the supply demand mismatch, and then can have a chest pain. So how you approach to a patient who have had such kind of element? So history and risk factors. Careful history is the cornerstone of a diagnosis of angina, because history should also include any of the manifestation of CVD and risk factors. We also should see that there are multiple factors that should be looked upon when you are asking a patient about coronary artery disease or ischemic heart disease. So as sir were discussing about that, most of the patients who just come to your outpatient department are asymptomatic, but then they have some family history of coronary disease, they are dyslipidemic, they have diabetes and hypertension, they continue to have smoking, they are hypertensive in past, or they are quite morbidly obese. And such patients, even without any significant symptomatology, should be screened for coronary disease. On the other hand, somebody who is not having any family history of coronary disease, his lipids are normal, he is normotensive, euglycemic, no addictions in past, does regular exercise, and he comes and tells you that he has some chest pain, typical of that something छातीत चमक निघते वगैरे प्रकार, त्यावेळेला definitely you can think that this is not going to be something very significant, and this is not a coronary artery disease. So I think the most important thing when you evaluate any of your patients, what is most important is you understand, you get his history completely, because as sir was mentioning, that not every chamak is something we can label it that it is non-anginal, but then each and every patient describe his symptoms in a different language. So we also know that in our region, in different districts, the people mention their symptoms in a very different language, and most of the times you may not just rely that this particular patient is complaining of chest pain or it is something else. So I think it is not just the history that the patient tells, but it is also the risk factors assessment that is important. So how a characteristic, what is the characteristic of a typical angina? How a patient should describe angina, or what you should suspect when the patient is telling something to you? So the most important thing of typical angina is location. One important thing is it is in the chest, in middle of the chest, near the sternum, but it can be felt anywhere from the epigastrium to lower jaw or teeth, or between the two shoulder blades, or in even arm and wrist and fingers. So we all know that, as sir has previously shown some diagrams where we can know that it is starting from the lower jaw till umbilicus. Anywhere you can have the patient, the chest, the anginal pain. The typical character is that it is a discomfort that is often described as pressure, tightness, or heaviness. Sometimes it can be strangling, constricting, or burning. So retrosternal burning that we say, but it is very unlikely that it can be just a small lightning pen. So, and that is why that particular kind of pain, what is being described by most of the patient, that छातीत चमकतंय, हे ज्या वेळेला डिस्क्राइब केलं जातं पेशंट कडनं, त्यावेळेला तो few seconds साठी असणारा पेन is very unlikely that it will be related to heart. The duration of the discomfort, that is which is brief, but say less than around 10 minutes, but not few seconds. So that is how the majority of cases will present to you. More commonly, it is just few minutes or less, and just when last for seconds is unlikely due to coronary artery disease. So the most important relationship to exertion, because any pain that increases with exertion, it can be labeled as anginal pain, and it is relieved by rest or nitrates can be labeled as an anginal pain. So how we can describe a typical angina? So any pain which meets three of the following characteristics. So whenever you get a patient with chest pain, you should just find out whether the patient has the typical 1, 2, 3 characteristic of pain. One is it's a constricting discomfort in front of chest or in neck, jaw, shoulder, or arm. So it can be either left shoulder or right shoulder. So both the shoulders can have pain when a patient presents with an angina, or say even for that purpose STEMI. It is precipitated by physical exertion, and thirdly, it is relieved by rest or nitrates within 5 minutes. So a typical angina meets all the three characteristics. When you label it as atypical, when there are two of these characteristics are present, and if only one of these characteristics is present, it is usually a non-anginal pain. So either one or none of these above three mentioned. The Canadian Cardiovascular Society typically describes this particular pain into four groups. So grade 1, 2, 3, and 4. The grade 1 angina is angina that is only with strenuous exertion. And there is a presence of angina during strenuous, rapid, or prolonged ordinary activity, like walking or climbing stairs. When patient does a moderate exertion and he gets pain, like doing slight limitation of ordinary activities, when they are performed rapidly after meals, so postprandial kind of pain, when it is done in cold, in wind, some emotional stress, or during first few hours after waking up. So such kind of pain can be graded as grade 2 angina. Such kind of pain also can come when you're walking uphill, when you're climbing more than one flight of stairs at a normal pace or in normal condition. Then a grade 3 angina is something where angina can occur with mild exertion. So having difficulties walking 1 or 2 blocks or climbing one flight of stairs even at normal pace and condition will be labeled as angina with mild exertion. And then lastly, grade 4 angina, that is angina at rest. Activities that precipitate angina are very, very important. The common activities that precipitate angina is physical exertion, some cold exposure, heavy meal, and intense emotion. Uncommonly, patients can have some vivid dreams and they develop angina. Nocturnal angina can be there like this. And then patients who have decubitus angina, or like somebody is lying flat and he's developing angina, will be called as a decubitus angina. Such kind of angina usually occurs in a patient who has severe aortic regurgitation just because prolongation of the cardiac cycle because of bradycardia at night, and then usually that leads to the decreased flow in the coronary arteries, which leads to have pain in chest. So what are the factors, like physical factors that are important? One is to assess the presence of hypertension, valvular heart disease, the peripheral vascular disease. Why peripheral vascular disease? Because almost 1/3 of the patients having peripheral vascular disease have coronary artery disease, significant coronary artery disease, and that is why those patients having peripheral vascular disease should be examined carefully and to be put for the coronary, subjected for coronary angiography if required. Those having HOCM and chest pain, definitely you just can't know that whether this patient has coronary disease or not until you do angiography. BMI is very important. We should see that those patients who are overweight and should be examined properly and found should be considered as a risk factor for the coronary artery disease. Waist circumference again is very, very important. What are the biochemical tests you do for such patients? We should do the complete hemogram, do the plasma blood glucose level, HbA1c. So that is a 3-month average of the blood sugar level. Then the lipid profile, serum creatinine and eGFR, serum uric acid test, the thyroid function test, and troponin levels if the patient is a suspected case of having an acute coronary syndrome in addition. So even in typical angina, we should always, so these are the blood tests that should be considered. So doing a resting ECG is the next step that should be done. So even in a patient with typical angina chest pain, they are present, even half of the patients may have very, very normal ECG. And even patients with STEMI sometimes have initial ECG, which is absolutely normal. And that is why doing an ECG at serial intervals is something which is most importantly recommended. A resting 12-lead ECG is recommended in all the patients with chest pain without an obvious non-cardiac cause. So this is the bracket mentions the level of evidence, and this is something according to the European guidelines with new evidences for any particular test we are doing. So a 12-lead ECG should be done in such patients. A very, very simple, most effective, cost-effective test that should be done in all patients having angina. I think with the STEMI program, we are doing the same, and that is how it should go. A resting 12-lead ECG is recommended in all of the patients during and immediately after an episode of angina suspected to be indicative of clinical instability. And ambulatory ECG is recommended only in patients where the patient have chest pain with suspected arrhythmia. So this is a class 1 level C recommendation. So you need not go in detail about what kind of the levels or the classes that has been put by ESC, but keep in mind that for each and every patient, the most important and foremost test is ECG. Resting ECG will guide you about having a very clear idea about whether the patient has STEMI or kind of an ACS to be presented with, which is of course a serious matter. For the patients who you are suspected and the basic ECG is normal, you should try repeating ECGs at every 15 to 20 minutes. And this will help you find whether the patient has some dynamic ECG changes, and that can again lead to a very good diagnosis of having a coronary artery disease. Rarely, if the patient's serial ECGs are normal and he's complaining of some kind of palpitations or chest pain on and off, you can do something called as the Holter monitoring or ambulatory ECG monitoring. Next is about the role of echocardiography in patients where the patients are presenting to your outpatient department. So a resting transthoracic echocardiogram is something which is recommended in all the patients for exclusion of alternative cause of angina. So as we know, most of the patients have atherosclerotic coronary artery disease, and you know that you cannot see you cannot identify the coronary artery disease in a patient with an echocardiography, but at least you can know whether there is some regional wall motion abnormality which suggests coronary disease. If there is no RWMA, that is resting, there is no wall motion abnormalities, that can also suffice that no, at least at rest there is no significant myocardial oxygen deprivation. But then there can be some alternative cause of an angina, like the patient can have severe AS rather than having coronary disease, and that can come as a diagnosis. Or a patient can have HOCM, and that can be diagnosed very easily by 2D cardiography. You can also measure the LVEF for risk stratification. So somebody who has presented with angina and now you do his 2D echocardiography, you find that his 2D echo EF, LVEF is say around 60%, then you can be sure that at least he has not infarcted in past. That means now once you do his coronary artery revascularization, he will definitely have a normal LVEF. But then the patient who had a heart attack in past, his LVEF is low, or he has some myocardial area which is scarred completely, definitely that means the patient is high risk subset for further cardiac events in his future. And lastly, the evaluation of diastolic dysfunction. There are patients who develop dyspnea on exertion. Their coronary arteries are absolutely normal, but then they continue to have dyspnea or some effort-related chest discomfort, and such patients usually have something called as HFpEF, where the diastolic dysfunction or diastolic heart failure is important. And in all such patients, the 2D echocardiography is very important. Chest X-ray is recommended in the patients who have typical presentation of signs and symptoms of heart failure and suspicion of pulmonary artery disease. Exercise ECG is something which is recommended for assessment of exercise tolerance. So exercise ECG is nothing but stress test or treadmill test, TMT, what we in general call. So this particular test is recommended if the patient has good exercise tolerance. You can just ask him to do some say 10 minutes of walk on this particular treadmill, and you can assess him to have whether he gets some symptoms, whether he gets arrhythmia, whether there is any specific BP response. This is particularly seen in patients with HOCM and the event risk in such a selected group of patients. It is not recommended for diagnostic purpose in patient who has already have an ST depression more than 1 mm in resting ECG, or who is already being treated with digitalis. So in such patient, it should be avoided. Otherwise, it is very simple and effective test that can be done in patients to diagnose the chronic coronary. So somebody was asking how to assess or how to evaluate the patient, or how to screen somebody for having coronary disease. So such patients definitely can be referred for doing stress test. What are the other functional non-invasive tests that can be done to evaluate such patients? So it can be stress echocardiography, doing something called as dobutamine stress echo can clearly tell you about the presence of coronary artery disease in most of the patients with accuracy, even if you are not subjecting the patients for coronary angiography. So it is a non-invasive and very good test, otherwise very specific test. Then SPECT, single photon emission CT, where we can do something called a stress MPI and find out whether the patient's particular myocardial area is deprived of blood supply. then myocardial contrast echocardiography or contrast cardiac MRI also can help you find the patient's coronary artery disease. So invasive test is of course coronary. It is the one and only invasive test, that is coronary angiography, and here you can find out the coronary disease by doing either by radial or femoral route, going inside, finding out the coronary vessels whether they are diseased or not. So what is important is whenever you are suspecting some kind of coronary disease, you should find out what is the pre-test probability of that particular patient. That means what is the likelihood that patient will have coronary disease. If somebody is doing a stress test and his test is normal, there is very less likelihood, less than 10% chance that he will have some kind of coronary disease. Somebody's coronary calcium score is 0, then again that means that the pre-test probability that he will be having coronary disease is very less. And for such patients, you can just definitely avoid coronary or any kind of invasive testing. Why in the patients who have had the specific risk factors like the dyslipidemia, diabetes, hypertension, smoking, family history, those patients having some resting ECG changes, those having some LV dysfunction. So patient is presenting with angina, you do his 2D echo, you find out that there's LV dysfunction. He should be subject to coronary angiography. That should be invasive one and not the CT coronary angiography. So abnormal exercise or stress test, exercise ECG means stress test. So abnormal stress test definitely should be subjected for coronary angiography, and those with coronary calcium score, which is increased by CT angiography, should again be subjected for coronary angiography. So there are patients where the patients once they are tested by non-invasive test, if they find if they show that there is some ongoing symptoms, we should do invasive coronary angiography to clear the diagnosis, to rule out the coronary artery disease. And it is always preferential if the patient overall has a very high likelihood by having symptoms which are refractory medical therapy, they continue to have typical angina at even low level of exercise, and those having LV dysfunction. So all patients, even the suspected diagnosis is different, will lead to like somebody has done a CT angiography and then you don't have a very suspected plaque, but then he continues to have symptoms, you should rule out by doing invasive coronary angiography. What should be your approach for initial diagnosis and management of patients with angina and suspected coronary disease? So generally, if the likelihood is low, then you can definitely subject patient for coronary CT angiography, and it can be a choice based on the likelihood of, again, the availability and the expertise. While if you are very sure and the patient's likelihood for having an obstructive coronary disease is more, in such patients, invasive coronary angiography along with FFR is recommended to see whether it is a true obstructive coronary disease. Coming to the management part, so lifestyle modification is the most important. Controlling of risk factors, pharmacological management, and revascularization all form very important role in management of chronic coronary syndrome too. So the lifestyle recommendations for the patients having coronary syndrome, first important is smoking cessation. I think we were discussing about the young MIs that are being presented in recent era. Most important risk factor is the stress, the smoking, and I think smoking cessation is something which is very important to have or reduce the incidence of young MI. So use pharmacological and behavioral strategies to help the patients to quit smoking, and also you should encourage people to avoid passive smoking, and that will actually make even the environment better. The healthy diet is something which is important. Healthy diet includes the plenty of vegetables, fruits, and whole grains, limiting your saturated fat to less than 10% of total intake, limiting alcohol to less than 100 grams per week or 15 grams per day. Physical activity, 30 to 60 minutes of moderate physical activity is very important. But even people, those having irregular activity, is beneficial. So very important that everybody should have some moderate physical activity. Maintaining healthy weight or BMI of less than 25. In Indian context, it should be even less than 23 kilograms per meter square of body surface area, and reduce weight by recommended energy intake and increasing the physical activity. Taking medication that has been as prescribed. Sexual activity is low risk for stable patients and not symptomatic, low to moderate activity levels. So coming to the healthy diet, so generally this prescription of healthy diet will include increasing the consumption of fruits and vegetables, which should be more than 200 grams each day. Then 35 to 45 grams of fibers per day. It is preferably should be the whole grain. Moderate consumption of nuts, approximately 30 grams, which should be unsalted. 1 to 2 servings of fish per week is okay. 1 to 2, it can be an oily fish specifically. A limited lean meat or low-fat dairy products and liquid vegetable oils are okay. Saturated fats should be reduced to less than 10% of total energy intake and then replace preferably them with polyunsaturated fatty acids. Polyunsaturated, PUFA, what we say. As little intake of trans unsaturated fats as possible. That is very important. Once you reduce that trans fats, that can definitely lower your cholesterol level. Preferably, there should be no intake from the processed food and less than 1% of total energy intake should be from the processed food. Less than 5 grams of salt per day. Alcohol already we discussed in last slide. And it is very important to avoid energy-dense foods such as sugar-sweetened soft drinks. Recommendations on lifestyle management. These are all what we see as per the class 1A by ESC. So improvement in lifestyle factor is class 1A recommendation. Cognitive behavioral interventions are recommended to change the smoking. Then exercise-based cardiac rehabilitation programs are effective and they're very important in patients with CCS, that is chronic coronary syndrome, to achieve healthy lifestyle and managing the risk factors. It should be a multidisciplinary approach wherein a cardiologist, a general practitioner, nurse, dietitian, physiotherapist, even a psychologist and pharmacist all should form a team and then treat that particular patient. Psychological interventions are recommended because such patients may have depression in their future, and it is very important in general that they should be seen by some psychologist. Influenza vaccines are recommended for elderly patients. Coming to the pharmacological management part, as been already discussed, nitrates are most important. They act directly on vascular smooth muscle to produce venous and arteriolar vasodilation. They help angina by lowering preload and afterload, but then they don't have a mortality benefit or they cannot prevent a heart attack because this is something which is a myth in most of the patients or in general population. Short-acting nitrates for acute effort angina, sublingual spray of nitroglycerin can also help. Long-acting nitrates are for angina prophylaxis. The beta blockers, they again lower the myocardial oxygen demand by reducing the heart rate, blood pressure, and myocardial contractility. Discontinuation should be tapered and not abrupt. The principal side effects are fatigue, depression, bradycardia, heart blocks, and sometimes bronchospasm. Peripheral vasoconstriction is associated with most of them, and not with some drugs like nebivolol. The calcium channel blockers, again, they lower the myocardial oxygen demand by reducing blood pressure and the myocardial contraction. The drugs like nicorandil, which are potassium channel activators in a dose of 10 to 30 milligrams, they again are quite effective. The side effects include headache is most important side effect here. I just forgot to mention there, but then it is one of the most important risk, the side effect of nicorandil. Otherwise, it's very well tolerated and almost BP neutral. Ivapride is again a very new and first of its class drug. It actually blocks something called as spinning currents and doesn't inhibit the myocardial contractility, appear to be safe in patients with heart failure. And of course, the side effects include bradycardia, but generally it is well tolerated. The ranolazine, again a selective inhibitor of late inward sodium current in coronary artery smooth muscle cell. The side effects include the dizziness, nausea, constipation, and sometimes QT prolongation. So that should be monitored in patients who are receiving the ranolazine. And especially if the patient is on some other drugs which are causing QT prolongation, like say amiodarone. To such patients, you should be careful giving ranolazine. And this is given in a dose of 500 to 1000 milligrams per day. Trimetazine, again a very good anti-ischemic and anti-anginal drug, which has some the metabolic modulator kind of effect. It actually improves the myocardial glucose utilization by inhibiting the fatty acid metabolism and also known as fatty acid oxidation inhibitor. It is contraindicated in patients having Parkinson's disease or some motion disorders like tremors or restless leg syndrome. How you prevent an event? So most important recommendation to prevent an event in the patients with chronic coronary syndrome, the class 1A recommendation is giving them aspirin 75 to 100 milligrams daily. So those having previous MI or revascularization, so you should continue aspirin lifelong in such patient. Clopidogrel is recommended as an alternative if the patient is not tolerating aspirin. So it is a class 1B recommendation. Anticoagulation has come up recently, and of course, for an acute event, you have the anticoagulation by parenteral route, like by heparin, low molecular heparin. But then the patients who have AF or those with recurrent ACS, of course, there is a role of some anticoagulant drugs like the nowadays the rivaroxaban. The next group of drugs is AC or ARVs. These are recommended in all the patients who have LV dysfunction. So post myocardial infarction, such patients should be put on the AC or ARVs. So preferably AC inhibitors because they have some mortality benefit. So those patients with heart failure and those with diabetes definitely should be on AC inhibitors. For statins are again recommended in all the patients with chronic coronary syndrome. It is class 1A recommendation. If patient's goal is not achieved with maximum tolerated dose of statin, combination of ezetimibe is recommended because that again lowers the LDL level to an specific target that we want. That too with the avoiding the side effects of statins. For those who have very high risk and still you are not achieving the target LDL with statin ezetimibe combination, you can even consider putting them on PCSK9 inhibitor, which has given parenteral either subcutaneous dose once every 15 days or 1 month, and nowadays we can now even have it at 6 months. So such kind of drugs can be given for lowering the LDL. So these are different antithrombotic therapies that can be used. So aspirin in dose of 75 to 100 milligrams, clopidogrel 75 milligrams daily who are aspirin intolerant. Then clopidogrel for patients who are, it can be considered in patients who are symptomatic or asymptomatic with either peripheral artery disease or some past history of PI. So there you can even consider clopidogrel in addition to aspirin. Those patients with the definitive evidence of coronary disease or past history, even without past history of MR revascularization, aspirin can definitely be added. Adding second antithrombotic drug to aspirin for long-term secondary prevention should be considered in patients with having a high risk of ischemic events without high bleeding. So we should always weigh a patient having having a high bleeding risk versus an ischemic event, and it is very important that patient should not bleed just because you are giving drugs for symptoms. So sometimes people just start dual antiplatelets and then rather patient comes with a very enormous bleeding, rather having some ischemic event in his life. So it is very important that we assess them and decide whether the patient really requires dual antiplatelet therapy. So where we require dual antiplatelet therapy, so the patients who have post-MI, he has tolerated dual antiplatelet therapy after revascularization, like for PCI, we give dual antiplatelet therapy for 1 year. And if then you want to continue patient on antiplatelet therapy, even clopidogrel, one single dose, a single drug is enough. Prasugrel can be even in patients in initial 1 year. If it is tolerated well and if there are some contraindication or side effects of ticagrelor, you can shift patients on prasugrel. But then again, there is very important criteria that patient's weight should be less than 60 and his age should not be more than 75. So such typical caution should be taken for patients who are being put on prasugrel. Otherwise, it is very well tolerated drug. Rivaroxaban again has come in patients having multivessel coronary disease. Even if their creatinine clearance is borderline, you can consider having putting the patients on this new drug called as rivaroxaban, which is an anticoagulant rather, and can be given in a dose of 2.5 milligrams BID in selected cases. Ticagrelor can be continued in patients where the post-MI revascularization is done already more than 1 year, and such patients you can reduce the dose from 90 to 60 milligrams BID. So these are the treatment options for dual antithrombotic therapy in patients having high risk of ischemic events. The suggested step-wise strategy for long-term anti-ischemic drug therapy in patients with CCS. The first step is always adding them on a beta blocker. So those with coronary disease, now definitely we all know that beta blockers as the forefront. They should be put initially in all such patients where it should be a standard therapy. So treating a patient with hypertension can be taken on this line also. And then along with that, adding calcium channel blockers if the blood pressures are still not controlled, adding the non DHP kind of calcium channel blockers where the heart rate is even more than 80 even after the good dose of beta blocker. If heart rate is low, in that case rather you can change to the drugs like the amlodipine, the calcium channel blockers, where we can consider good BP control without lowering the heart rate. Those with LV dysfunction, again, beta blockers along with the ACE-ARB are important. And those who are having very low blood pressure, there can be ivabradine, the ranolazine, trimetazidine, such a BP neutral drug that can be used for long-term anti-ischemic therapy. The revascularization in patients with CCS, the optimal medical therapy is the key for reducing the symptoms, halting the progression of atherosclerosis. So it can be either in the form of PCI or coronary artery bypass grafting, which will effectively relieve the angina. So wherever the option is, you should always revascularize the patient by the best possible strategy you can give it to your patient. So what are the changes? So coming to the last few slides of my talk, importantly, this particular chronic coronary syndrome, the term has coined by ESC in 2019. And what are the main changes that has been done by ESC? One is that they have included the exercise ECG and as an alternative test to rule in or rule out the coronary disease when other non-invasive or invasive imaging methods are not available. So it is very important that whenever you want to do basic health screening of a patient, it can be easily done by a stress test. Then exercise ECG should be considered in patients on treatment to evaluate the control of symptoms and ischemia. So anybody who has underwent a previous revascularization, now you want to evaluate the patient whether he is comfortable after his angioplasty or bypass, you can definitely do an exercise testing in such kind of patients. So in long run, all the patients who have been seen in that 6 scenarios can be evaluated by this particular thing. So that is a class 2B indication now. Then there are long-acting nitrates that should be considered as a second-line treatment option when the initial therapy fails. And then we can consider them putting on long-acting nitrates even. Then the nicorandil ranolazine, which were previously in class 2B recommendation, now has been put in the class 2A recommendation to reduce angina frequency, improve the exercise tolerance in subjects who cannot tolerate, have contraindications for the beta blockers or the CCBs or long-acting nitrates. In selected patients, the combination of beta blocker or a CCB with second-line drugs like ranolazine, nicorandin, ivabradine, and trimetazidine may be considered for first line of treatment according to the rate, blood pressure, and tolerance. So these are the few changes that has been done by the ESC. So previously these drugs were put in class 2B and now they have been shifted to class 2A for the angina management. I think with this, I come to end of my talk. I think if there are any questions, we can take that.
Sir, thank you very much. Wonderful session, sir. Any questions? All participants, please put questions in the chat box. We'll try to take one question one by one. Sir, meanwhile, can we start that video if it is possible?
Yeah,
Then
just find out. Yes.
let them put the questions in chat box so that after video we'll take the questions.
I think
Sir,
it's not
audio-
audible, right? Audio.
Audio is not coming, sir. Hello, sir. There's no audio from the video actually.
Yeah, I'm just trying to do that. Just a second.
So you just have to check on the that check box, share computer audio before sharing the file, no?
Okay.
Hello, on occasion of Hello, on occasion of World Heart Day, I would like to emphasize that heart disease is a predominantly lifestyle-related disease. Many believe that heart disease has genetic origin. It occurs because of hypertension, there is high blood pressure, diabetes, smoking. That is all true. However, one must remember that all the risk factors like diabetes, blood pressure, obesity, that is increased body weight, um, are all related to your lifestyle. So one must realize the fact that if right from the beginning, uh, if you pay attention to your lifestyle, you can have control on diseases like blood pressure, diabetes. You can not only have control, but you can prevent those diseases from occurring. And that ultimately will result in reduced incidence of heart disease. When you start developing blockages in your arteries, it's already too late. One must start acting when you are in school, when you are very young. And it is important for all the parents to pass this message on to their children at the right age. When they are all grown up and they're busy in their professional life, sometimes these basic things are neglected. So please make sure that they understand that heart disease is lifestyle related disease. It's about making proper choices. You are what your choices are. You are what you eat. You are what you do in your life of physical fitness. So please make sure on this occasion of World Heart Day that you understand the fact that heart disease is related to your lifestyle. Thank you.
So if there are any questions, we can continue. Otherwise, I think we can conclude our session.
Can you hear me, sir?
Yeah, I can hear.
Sir, thank you again for both the speakers. Sir, 2-3 questions are there.
Right.
First question is, nitrates are contraindicated in RVMI. How to know if patient is having RVMI when he or she is having ACS episode?
Yeah, so importantly, that is why nitrates are not very commonly or generally prescribed for all the patients having a MI, and because nitrates can definitely lead to have hypotension, and that is why they are contraindicated in patients who has an RVMI. What happens is a patient with inferior MI generally will have an chance that he may have inferior MI with RV extension. And such kind of patient, there is a possibility that they can develop a very serious hypotension. They can even land up with syncope, and such patients should be avoided with giving them nitrates. So now, how you diagnose that some patient is having RVMI? The important thing is there are some ECG changes that you should look into, and especially like as we know that the right ventricle is situated on the right side of the sternum. So whenever you are having suspecting RVMI, it is better you do some right sided leads which are called as RV leads. So RV1, RV2, RV3. The same as you are doing on the left side, the general V1, V2, V3, which go from the right to left. You just do reverse. So you do V1. So the normal V2 lead will be called as RV1. The normal V1 lead will be called as RV2, and then so on. So then V3 and V4. And if now you find out the ST elevation in such patients in these particular leads, that is RV1, 2, 3, 4, you can suspect that this particular patient has RVMI. And in such patients, it is very important that you should not give nitrates. I will rather say it is better not to give nitrates in patients with infrared MI itself, because such patients definitely can land up with hypotension if you give them nitrates.
Okay. Sir, next question is here. For how long to continue clopidogrel ecosprin in patients with chronic stable angina?
No, see, patient generally, as we already discussed, if the patient has undergone some kind of reaspiration procedure, especially the PTCA, if the patient has been put some stent, it is better you continue dual antiplatelet for 1 year initially. After 1 year, if patient doesn't have any contraindication, any side effects because of this dual antiplatelet like bleeding, it is definitely required that they should be there should be some reduction in the dose. Say, so the patient is on ticagrelor for initial 1 year, you can switch to clopidogrel after 1 year. And such patients can be continued for the dual antiplatelet therapy for minimum of 2 years. There is no further data. So as such, if you go to the guidelines, there is no further data to when to stop dual antiplatelet therapy, but it all depends on the particular subject. Like somebody has multiple risk factors, somebody continues to smoke, somebody who is very much drug non-compliant, it is better you continue, or somebody has some other risk factors like CVA or peripheral vasculitis, it is preferable that you continue them on dual antiplatelets. If patient is young guy who is not smoker, had some ACS with a thrombotic kind of pathology when we did his angioplasty, it is better you stop the dual antiplatelet, switch to a single antiplatelet after 1 year. So it is actually subjective and not a common rule as such.
Nice. So next question is how to differentiate between cardiac arrest and MI and its primary treatment in remote areas when tertiary care center is 3 to 4 hours long away.
See, these two are definitely different terminologies. One is myocardial infarction, where you have again either it can be a STEMI, the treatment of which is has been completely discussed by Sir. Then NSTEMI and unstable angina. These are the patients where again you can just continue them giving antiplatelets and the heparin initially, and then shift the patient for further angiography or invasive kind of testing that is required to find out the coronary disease. On the other hand, you have a group of patients who develop cardiac arrest just because they had a heart attack. So post-MI, somebody developing some kind of lethal arrhythmia, say for that purpose, it is an ventricular fibrillation. Such kind of patients, they can develop cardiac arrest, and in such cases, it is very important that patient should be resuscitated after this particular cardiac arrest. So how we do that? If the patient has a rhythm which is either ventricular tachycardia or ventricular fibrillation, you need to do something called as cardioversion. So that is done by the DC machine that we have in your our defibrillator machine that we have in most of the places. And I think a few of the PSCs definitely will be having the defibrillators, and that can be used to resuscitate such patient. Such patient again should be started on the cardiopulmonary resuscitation like cardiac massage, and this particular patient should be started on some drugs, antiarrhythmic drugs like amiodarone. So it all depends the scenario, whether the patient has developed it as an ischemic episode or whether it is just an cardiac arrest secondary to some old ischemic heart disease. Like say the patient has previous heart attack, there is a scar in his myocardium, now the patient develops a ventricular tachycardia. Most of the times it can be just a stable ventricular tachycardia. And such kind of patients definitely can be just treated by pharmacotherapy. You just start them on IV amiodarone, patient's ECG settles, and then further patient can be referred for the further treatment of, say, called as automated cardiac defibrillator or AICD. So again, as we said, the scenario is important, in which circumstances patient is presenting, and especially at the remote places, you should be ready for such emergency things that are to be done in the patient, because you just can't put patient in ambulance and send, because that can be a life threatening for that particular individual. So it is important that you start his initial resuscitation at your place and then send the patient to peripheral or tertiary care center.
So next question is, if Q-risk score is 15, should we give ecosprin?
Yeah, I don't think it is just some score that we should just think and give the antiplatelets. It is always again the individual stratification, especially if the patient has the other risk factors, including diabetes mellitus, dyslipidemia. If the patient has some evidence of atherosclerotic coronary disease or some even peripheral vascular disease, all such patients, they should be put on antiplatelets. It is preferable that we should put them on single antiplatelet and a statin, preferably. So in general, what we see is giving them ecosprin and atorvastatin combination.
Sir, what's the accuracy of coronary calcium score? After which age need to be done? At what interval? Similarly, about HSCRP.
See, again, the coronary calcium score is something which actually can just predict whether somebody is having some significant coronary artery disease. But then again, there are multiple evidences wherein we have very huge calcium score, and in patients when we subject to angiography, there is nothing intraluminal. So it all, again, it can be just an adventitial calcium sometimes. But then whether only that particular coronary artery calcium scoring should suffice? No, not at all. So if the patient's calcium score is high, it just tells you that there is a probability that this particular individual will have some coronary artery disease, and it doesn't mean that he definitely has it. But then definitely, as we see that there is a high likelihood or the pretest probability of having coronary artery disease is high when the patient has high coronary artery calcium score. So if it is more than 300, you can definitely say that this particular individual should be subjected for angiography, and he should be put in cath lab to see whether his coronary arteries are normal or not. So that is about one. And secondly is about the HSCRP. The HSCRP, though a very good test, and especially has come up more after the COVID era, but I think it is not very much specific for the heart, the cardiac element as such, because there are multiple other reasons where you have the HSCRP which is elevated, and because of that you can just cannot put patient or subject patient for doing some invasive testing. So HSCRP doing very oftenly is not recommended. It should be done in a context wherein the multiple other factors, like say somebody who's having no family history, there are no other significant risk factors. There is only a dyslipidemia that is there, and especially if the risk stratification is to be done in such particular patient, you can do HSCRP, lipoprotein A. And if everything is positive, then you can consider doing some non-invasive screening test for such kind of patient. So HSCRP is not something which is recommended usually.
I mean, these are just predictive or supportive. What do you call that?
Sir, next question is, kindly throw light on the role of aspirin and statin in prophylaxis of atherosclerotic plaque in hypertensives. Hello, sir. Can you hear us, sir? Sir, can you hear me?
Yeah. You heard the question, sir?
No, there are some connection error.
Yeah.
Can you?
I will tell you short. The role of aspirin and statin in the prophylaxis of atherosclerotic plaque. especially in hypertensive patients.
Yeah, so again, the same thing. If there is evidence that the particular patient had an atherosclerotic plaque, it is very much mandatory that the patient should be continued on aspirin and statin. It is not imperative that every hypertensive patient should be put on aspirin and atorvastatin. Most of the times, we often see such kind of prescription when a patient comes in our OPD being treated by some general physician outside, and once the hypertension diagnosis is made or diabetes diagnosis is made, they usually put these patients on a prophylaxis ecosprin and statin. But I think that is not something which is recommended. If a hypertension patient is dyslipidemic, again, we have very specific guidelines for dyslipidemia. It is very important that you should look the LDL level. If their LDL level without any kind of risk factor is more than 189, the patient should be put on statin without any hesitancy. If LDL level along with hypertension or diabetes, which are the risk factors, the additional risk factors, is between say 130 to 189, you can consider these patients putting on these statins. And if the patient has a very clear evidence of atherosclerotic heart disease, like the patient had previous heart attack or the coronary disease, he should be put on statin. So these are the only then you need not look if LDL level. Even if it is less than 130, you should put that particular patient on statin. So the role of statin and aspirin is only after the clear evidence of atherosclerotic heart disease or the particular level of dyslipidemia, and not for each and every individual with hypertension.
Sir, one last question is there. A little bit general question. Is a syncopial episode with the unknown cause is a good indication to do the stress test?
Yeah, see, syncope, as sir has just given one example, that one of our patients, say 2 days back, presented in our OPD with just the episode of syncope. And then when we did his angiography, it turned out to be a very critical lesion in his coronary artery. So the right coronary artery was huge, almost 4 mm size, had a very critical 90% lesion. Now, this particular scenario is very uncommon usually. What we generally have is we have patients who develop syncope if they have very significant. Are you able to hear me? There's some.
Yes.
So there are some scenarios wherein the patients, they may not have very clear evidence symptom like ischemia, chest pain, but then they can have sometimes some coronary disease and they present with syncope. So these are patients who have a very critical LED lesion sometimes, or those patients who have even the RC lesion as described by sir today. So it is very important that you find out why this particular episode has happened. Then syncope evaluation actually requires the 2D echocardiography examination, because that should be the first and foremost thing that is done, because sometimes a valvular disease should not be missed. And sometimes even the practice that is followed in some of the centers, that they just subject patient for stress test, not even like before doing the 2D echocardiography. I think that is something which is not, or that is something that should be avoided. And then exercise stress test sometimes can bring about the arrhythmias by which the patient has developed such kind of syncope. And I think for the routine syncope evaluation, you can first get his basic 2D cardiographic examination and then subject patient for a stress test if required.
Okay.
Yeah.
So these are the questions. Can you be with us for the next 5 minutes? Because we are having the post test, and in between, if any question comes.
Sure.
Is it possible, sir?
Yes, sir. I will be there.
Post test now. I have to make 2 important announcements. First is the just 1 minute. The 2 important announcements I have to make. The first is to solve pre-test and post-test is mandatory from the part of Maharashtra Medical Council. Pre and post-test solving is the mandatory for Maharashtra Medical Council to prove that you are actively participated in the online webinar to get the 1 MMC point. This is the question. This is my announcement number 1. And secondly, along with the clinical webinar each month, the SHRC also presenting the administrative webinar, which is very useful for you, all people who are serving in the PSC, RS, or having some in-charge, PSC MOs, in-charge MOs, or medical superintendents. We have the administrative knowledge. So we are having the administrative webinar every month on the third Wednesday. Now in this month, because of the assembly session, we are conducting the administrative webinar on the office record keeping and the pay fixation part 2 on the 20th of this month. 2/8 डिसेंबर 28 डिसेंबरला आपण ह्याच वेळेमध्ये आपण ऍडमिनिस्ट्रेटिव्ह वेबिनार घेत आहोत. बिकॉज ऑफ असेंब्ली सेशन आपण थोडं उशिरा घेतोय, नाही तर अदरवाईज आपल्याला तिसऱ्या मंगळवारी किंवा बुधवारी आपल्याला ऍडमिनिस्ट्रेटिव्ह वेबिनार आपण घेत असतो. आणि लिंक आहे सेम आहे, इको प्लॅटफॉर्मवर त्याची इन्फॉर्मेशन आहे. तुम्ही रजिस्टर केल्यानंतर तुम्हाला तिथं सगळे इन्फॉर्मेशन क्लिनिकल वेबिनारसाठी मिळू शकते. रिपीटेडली तुम्हाला रजिस्टर करायची गरज नाही. वन्स यू आर रजिस्टर्ड इन द इको प्लॅटफॉर्म, द बोथ webinars are available to you. So kindly join for the administrative webinar also to gain the administrative knowledge, which is very useful for personal things. Thank you. आता मी पोस्ट टेस्ट टाकलेली आहे, चॅटबॉक्स मध्ये टाकलेली आहे. सगळ्यांना रिक्वेस्ट आहे की पोस्ट टेस्ट सॉल्व्ह करावी. आणि दरम्यानच्या काळात मी सरांना आता रिक्वेस्ट केल्याप्रमाणे जर कोणाला एखादा दुसरा प्रश्न अजून जर सांगायचं असेल, विचारायचं असेल की लिहायचं असेल चॅटबॉक्स मध्ये, तर यू आर परमिटेड फॉर नेक्स्ट 5 minutes. थँक्यू. डॉक्टर सोनाने सर, थँक्यू फॉर जॉईनिंग. मी पाहिलं तुम्हाला आता.
थँक्यू सर. मी एडीएस मेडिकल ठाण्याच्या 2-3 दिवस चार्ज चाकूरकर सर बाहेर लखनौला गेले.
तुम्हाला पीएससी मॅन्युअल साठी आम्ही बोलवतोय, पण तुम्ही सापडत नाहीयेत. तुम्हाला पकडतो.
थँक्यू. ते एक्झाम होते ना, ग्रुप सीडीचे एक्झाम्स.
हो हो.
त्यामुळे मी ठाण्याचा नोडल ऑफिसर असल्यामुळे मला नाही घेता आलं.
नाही, आता 28-29 मी बोलवतो तुम्हाला. काइंड परमिशन घेऊन.
थँक्यू सर. थँक्यू. येस सर. सर हे पोस्ट टेस्टचा दोन्ही पेशंट एक ओपन करायचं आहे का? दोन्ही पैकी एक.
हा, पोस्ट टेस्टची लिंक आता टाकली सर, आता ती ओपन करा. ती ओपन करा. हा, तेवढीच. पालकर सर आहात ना? पालकर सर. सर एक क्वेश्चन आलेला आहे. कॅन वी कन्सिडर द स्ट्रेस टेस्ट इन अ पेशंट विथ अ trivial MS MR TR and the moderate to severe LV diastolic dysfunction?
See, valvular heart disease, the only contraindication that we should usually see is having some severe mitral stenosis or severe aortic stenosis. These are the two conditions where it is better not to do an stress test. Those with trivial MR and all that, definitely you can consider doing the stress test. But again, now, as sir has already has mentioned about 2-3 things in this particular patient's information, that is having moderate to severe LV dysfunction. If the patient's LV dysfunction, meaning that there are some regional wall motion abnormality and the LVEF is less than say 35%, it is better to avoid stress test at least as a first thing, unless and until the patient is known to have such kind of LV dysfunction in past. Like I had done one patient's angiography, angioplasty, and then his LVEF was 35% 1 year back. Now he is coming for a routine evaluation and he has trivial MR, trivial TR, and the LV dysfunction. I can definitely do his stress test. But if the patient is having or on the first time he is presenting to you and he is having moderate to severe LV dysfunction, you should first rule out the coronary disease and not subject the patient for stress test. I think I am clear with this.
Question आहे, anti-hypertensive drug of choice with the moderate LV diastolic dysfunction in elderly.
LV diastolic dysfunction, you can put it in the grades 1, 2, 3, 4, and not with like this mild moderate term. So if an LV patient, if the patient has a diastolic dysfunction and then he is actually having some symptoms of heart failure even, it is preferable that such patient should be started on AC or ARB inhibitors. Then along with this, nowadays we have data for ARNI. wherein the patient's LVEF, if it is around, say, 50 to 55%, not more than, actually they put it as more than 57%, but we will put it for a simpler version, we'll put it just 50 to 55%. So those with preserved EF, even the ARNI can be given. So we know that nowadays the ARNI has been advocated for all patients with LV dysfunction, but even those patients who have diastolic dysfunction with a relatively preserved EF, you can consider them putting on ARNI.
Okay, thank you, sir. Any other question is there?
कोणाचा क्वेश्चन आहे का अजून? सर एक रिक्वेस्ट होती, आपण एक MCQs दिले होते 5, त्याची आन्सर्स तुम्ही जर तुम्ही जर ब्रीफ केलं सगळ्यांना तर बरं होईल.
ओके,
मी शेअर करतो सर इथे.
You can share that so that I will be able to read.
हा, मी शेअर करतो.
Yes.
Sir, can you read, sir?
Yeah. So
Yes.
basically, the framing of question was such that I have covered most of these points in my lecture itself, and it is also for the better understanding that generally we come across with some of the basic questions that most of the doctors, the physicians tend to ask us in our routine day-to-day practice. So first question is, which of the following is characteristic of typical angina? So as we already discussed, it has typically 3 characteristics. One is constricting discomfort in front of chest or neck, jaw, shoulder, or arm, and it is precipitated by physical exertion. It is relieved by rest or nitrates within 5 minutes. So all of the 4 answers, all of the 3 options, that is D, all of the above is correct answer. The next question is, which of the following is not a suspected or established chronic coronary syndrome? So basically, this was in relevance to the topic we discussed, the scenario. There are 6 different scenarios that we have seen, that a patient who presents with a suspected coronary disease and stable angina symptoms or dyspnea in past. So this is something who is a suspected coronary disease of CCS class. Then the second group is patients with acute or chronic onset heart failure or LV dysfunction and suspected coronary disease. So in B option, we have the subset who has presented acutely when he had the previous history of heart failure. And what we have discussed in our scenarios, there's a patient who is presenting on first time. So it is a new onset heart failure that should have been there. So here the B, B answer is correct, as it is not a chronic or established chronic coronary syndrome. The third option was patients with angina and suspected vasospastic and microvascular disease. So that is correct. That is a type 5th of this particular scenario. And the 4th, the asymptomatic subjects in whom CAD is detected at screening, again is true regarding the suspected and established CCS. So we'll go to the next question. Which of the following is not an etiology for chronic coronary syndrome? So basically, as we discussed, atheroma, most common cause, valvular heart disease like aortic stenosis is the cause for chronic coronary syndrome. Vasculitis can cause chronic coronary syndrome. Anemia also can cause chronic coronary syndrome. But D, that is arrhythmias, will never cause a chronic coronary syndrome because they will be transient and they will not lead to have chest pain as such. Okay. So I think D is the answer there. 4. Next question is, the role of 2D echo color Doppler examination is recommended in all of these for the following indications except. So first is option is exclusion of alternative causes of angina. So as we said, we can find out whether there is some valvular heart disease which is causing angina. So that is absolutely correct for 2D echo. Then identification of RWA, that is regional wall motion abnormality, which suggests CAD, that is also correct. Thirdly, identification of the measurement of LVF for risk stratification is also correct. But then identification of coronary artery disease is not possible by 2D echo. So again, sometimes this particular thing is confused. Most of the people say, sir, फक्त echo करून जमेल का? तर नाही. फक्त echo करून आपल्याला coronary artery disease बद्दल माहिती नाही मिळणार. Because at rest, sometimes your echo will be normal and you will have a triple vessel disease. So that is possible. So we cannot identify coronary disease on 2D echo. So answer is C. Which of the following is true regarding nitrates? So again, this particular thing is quite mistaken at most of the places and in many meetings. That is why I have kept this particular question. Nitrates, as we know, that they help in relieving angina by lowering preload and afterload. They doesn't have any mortality benefit and they cannot prevent an heart attack. They are just to relieve your symptoms and not to prevent an heart attack. Rather, that is why sir also said that it is better you give them aspirin. That is something which is most important. So nitrates are not going to prevent any of these further events, but they are very important in treatment in relieving the symptoms of the patient, especially in those with chronic coronary syndrome. So I think answer here is A and not all of the above. Okay.
Thank you, sir.
So thank you for answering our test questions. Yeah, what we the result got from the 115 answers we have got of the pre-test. The most misleading was this question.
Yes.
And the maximum percentage got is 23% got correct answer. And one of the questions got is 70%. So this webinar is very helpful for our medical officers to get the correct knowledge or to enhance the knowledge or to update their knowledge. I once again thank you, Dr. Ranjit sir, and I also thanks all my medical officers and the participants, those who have joined for our clinical webinar. I request you to do join the next webinar next month, clinical webinar as well as the administrative webinar, which is occurring every month. Thank you very much, sir.
Thank you, sir. Thank you for the opportunity. Yes.
Hello, sir. Hello.
Yeah.
Sir, what are the indications for bypass surgery, sir? Please guide.
So basically, any patient who presents with such acute coronary syndrome and we subject or say even for that purpose stable coronary artery disease, we subject them for coronary angiography and we do an angiography. If we find a triple vessel disease and that too with involvement of left main coronary artery disease, if the patient has some previous history of diabetes mellitus, all such patients should be subjected or recommended for the coronary artery bypass grafting. Nowadays, with advancements of stents, definitely the coronary angioplasty has become more advisable for most of our patients, and most of them can be managed by angioplasty. Even if they have multiple lesions, the left main disease even can be tackled by doing some IVUS guided coronary angioplasty. But still, if the patient has the critical left main disease and the involvement of all the three, especially the left anterior descending artery disease, and the patient has past history of diabetes mellitus, the first option for the revascularization should be coronary artery bypass grafting for such patients.
Thank you, sir. I think there are no more questions from the participants. I once again thanks everybody.
Sir, one last question is there.
Hello? Why you are not writing in the chat box previously?
Okay, sir. Sorry, sir.
Okay, ask that question.
Sir, some MD Ayurveda doctors are saying Madhav Bhag is helping for diabetes and coronary artery disease, sir. What is the role? Please guide.
See, this definitely there is a lot of improvement after most of the research that has been made in the Ayurvedic practice. But then I personally feel that it is always better you get most of the things evaluated properly, see whether there is something which is possible by doing some kind of revascularization procedure, and the number of multiple medical options that we have now presently, the medical sciences has advanced so much. It is always better that we stick and find out the better solutions by getting patient evaluated properly. The centers where there are the all kind of investigations that are discussed today are available. And if after that the patient is subjected for resuscitation procedure, he has given the different medications that has been discussed, and still patient is symptomatic, if there are no further treatment options available, like some patient has inoperable coronary artery disease, or some patient has very diffuse coronary artery disease, and then you are not with any kind of option, then definitely you have role of all these bag, or even that ECP, the extra corporeal counter pulsation therapy, and chelation therapy, that everything is advised. But I think all this should be only the options. These are the last resorts. I definitely don't recommend them, but then it is only up to the patient after continuing their optimal medical therapy that is guided by the different guidelines to be continued, and then shift to such kind of alternative therapies.
हॅलो सर, डॉक्टर देशमुख बोलतोय सर.
हा बोला सर.
हा, आपण आता जे ECP म्हणलात ना,
हा.
it is actually there is any role of ECP because government doesn't accept that therapy.
No, actually, sir, if you see the guidelines now recently, there is a class 2B in recommendation with ECP nowadays. That is only after, and it is only for those patients where it is inoperable coronary disease. Like now we see in Indian subset specifically, where the patient have a long-standing diabetes, such patients tend to have very long segment diffuse disease, and such patients, you just can't do any bypass surgery just because there is no place to put a graft. And then as an interventional cardiologist, I can even not put a stent. For all such patients, for some kind of natural bypass that is to be formed in such a particular patient, ECP is recommended only in such group of patients. And we have one center in Aurangabad. When I was doing my post-graduation in Chennai, there were quite a few centers doing ECP. And although it was not recommended in past, now it is recommended only for such a subgroup of patients where you just can't do anything for patients. So I think there is no harm in doing ECP. We don't definitely know whether the patient will benefit out of it or not. So it is in addition to the medical therapy, and in only those cases where you just can't do anything for patient in terms of revascularization, either by bypass or angioplasty.
As a palliative care measure.
Yes, you may consider like that. Yes.
Yeah. Okay, sir. Thank you very much. And I hereby declare that our today's clinical webinar is over. Thank you.
Thank you, sir.